going to start talking about cardiovascular disorders and dysfunction. With cardiovascular disorders, we're going to cover not only risk management and what nursing care looks like. With somebody or a child who has cardiac disorders, we're going to delve into those congenital heart defects. And then we're also going to talk about acquired heart disease later on in this chapter. So this is a heavy chapter. So get ready for it because there's lots of information coming your way. We're going to start talking about cardiovascular disorders and dysfunction. With cardiovascular disorders, we're going to cover not only risk management and what nursing care looks like. With somebody or a child who has cardiac disorders, we're going to delve into those congenital heart defects. And then we're also going to talk about acquired heart disease later on in this chapter. So this is a heavy chapter. So get ready for it because there's lots of information coming your way. We're going to start talking about cardiovascular disorders with children. When we talk about cardiovascular disorders, we have to look at health promotion and risk management. So health promotion and risk management is really just getting into what are the risk factors that certainly lead to adult heart disease. We know obesity, high cholesterol levels, lack of consistent exercise. It really is looking at those healthy habits, right? So we want to make sure we're establishing healthy habits in childhood to try to avoid some of these adult cardiovascular disease. So prevention of cardiac disease has really shifted to more of a child focus, looking at early interventions and having major impacts on the decrease in incidence or decreasing the incidence of preventable heart disease. So when we talk about risk management for congenital heart disease, we really look at associations with familial patterns of inheritance. We know that if there is a parent or a sibling that has a congenital heart defect, there's definitely a higher risk for any offspring or another sibling to have a congenital heart defect. So important to assess familial patterns of inheritance. Women need to be fully immunized entering pregnancy to try and prevent infection during pregnancy. Parents who have family members born with a heart disorder need to be aware that, again, other children born need to be carefully screened prenatally and at birth for similar disorders. And then getting into risk management of acquired heart disease. And acquired heart disease, to name a few that we're going to talk about, congestive heart failure, rheumatic fever, infectious endocarditis, and Kawasaki's disease. These are all different ones we're going to actually talk about later on in this chapter. But when we're assessing risk management for acquired heart disease, we're looking at identifying those risk factors. Those include, I'm going to hit kind of the big ones, rheumatic fever, looking at following a beta hemolytic streptococcal infection. They're, especially if they don't get properly treated or finish the course of antibiotics, they're at risk for developing something called rheumatic fever, a complication from that recent strep infection. So really important to try and prevent that all children who have a streptococcal infection receive adequate antibiotic therapy. Again, trying to avoid that complication. Hypertension. It's associated with a genetic predisposition. There are other factors like high intake of sodium, lack of exercise that just increases that chance, and again with obesity, increases that chance for hypertension. And hypertension can lead to changes in the left ventricle if it's not managed well. We want to urge families to try and decrease the intake of processed foods and snacks because those type of foods have high salt content. So if we can get them to decrease the amount of processed foods and snacks, then ideally that's going to lead to decreased salt intake. By the age of 3, we talked about this back in growth and development, we start screening blood pressures in kids. We don't routinely do it prior to age 3 unless there was an actual concern or an illness. We usually routinely start tracking those or screening blood pressures at age 3 as part of those wellness checks. So blood pressure should be included at routine assessments, and that's really trying to detect early any hypertension issues. And then we also look at hyperlipidemia as a um, issue for acquired heart disease. It tends to be inherited. Diets that are high in saturated fat implicated in development of the metabolic syndrome. Fat intake should really be restricted in infants and toddlers, or I'm sorry, it should not be restricted in infants and toddlers because they need that fat for brain development. It's really important. But then once we get past the toddler period, we want to watch. It's not that it's not important, a small amount's okay. We're just looking at really the high fat content type foods and getting too much of that. So again, monitoring that in the other age groups, but infants and toddlers really do need it because it does help with brain development. For school age and adolescents, again, reducing fat intake to about 30% of their total calories can help reduce the chance for hyperlipidemia. And children who come from a high risk family need to be regularly screened for elevated cholesterol and triglyceride levels at routine visits. All families and children are encouraged to participate in routine aerobic physical exercise. Again, we've talked about that in growth and development. Get them out there getting moving. We just want them out moving, not sitting in front of a screen, a TV, phone, computer, anything that has, screen time means they're not active. So remember, we talked about how important exercise is. It doesn't have to be, you know, strenuous. It doesn't necessarily have to be structured. We just want them out there playing, moving those bodies and getting exercise. We're going to talk about nursing care of a child with a cardiac disorder. It would be important to provide or review information about care. Parents often have a lot of different questions when they find out their child has a cardiovascular disorder or disease. So it'd be important to certainly address those concerns or do some education to help them feel a little more comfortable with the care of their child. So, common question we might hear or get is it safe to let a baby with heart disease cry? Crying for a few minutes is not going to hurt the infant while that parent warms up that bottle or letting the baby cry a little bit if they're breastfed because that will help them kind of fully awaken. It's not going to cause any direct harm to the baby. If the child has no immediate needs that need to be met, like hunger, cold, or wet diapers, the child should be allowed to fuss. And that's partly so they learn how to self soothe and they're not being dependent on being held. Again, nothing wrong with holding a baby. You can't hold them too much. But again, we want an infant to learn how to self soothe, regardless of whether they have a cardiac disorder or not. Another common question: does our child need special nutrition? Again, breastfeeding is still a preferred method of feeding for a lot of families. And the average infant with heart disease can be successful at breastfeeding. It depends on the severity of whatever the heart disease is, congenital or acquired, and how much it's affecting them. Breastfeeding is work, both for especially for the I shouldn't say both, but for the infant, it does take a lot of effort. And if it is causing too much distress for the infant, then maybe we don't do breastfeeding. But average infant, even with heart disease, can be successful. Again, some infants with the congenital heart disease, they can tire easily. It may require that the mom needs to pump breast milk and then fortify it if necessary, especially if they're needing extra calories because of the metabolic demands on the body with the congenital heart disease or some of these congenital heart disease. They may need extra calories because they're basically burning through them too quickly. So sometimes if mom really wants to breastfeed or have the infant have breast milk, she may need to pump, and oftentimes we can fortify it with extra calories and then just feed from a bottle. And again, if a bottle is too much, there in some cases, it's infrequent, but some cases, if it's too much work and effort for the child and they're wearing out, there are sometimes cases where we need to feed them via an NG or an NJ tube for feeding. Another common question: how much activity can we allow the baby? It really depends on the type and the extent of the heart disorder. As a general rule, infants and young children will usually naturally limit their own activity and they'll stop when they're fatigued. They know when they're getting wore out and they just naturally will curb whatever their activity is that they're doing and kind of slow down and stop what they're doing. Uh, it's still important to encourage parents to observe an infant carefully or a toddler so they can really recognize signs of respiratory distress or easily being fatigued so that can give them a break. Right? And for older children, they're usually encouraged again to play as they desire and participate in those physical education classes. But varsity level type competition might need some restriction. So again, it depends on the particular child. It depends on the extent and the type of defect that we have or heart disorder that is occurring. Um, should children be followed again beyond just a cardiologist if they have a heart disorder? They should. They should still be seeing their primary care provider, so a pediatrician or family physician, in addition to that cardiologist, because the cardiologist is really going to focus on the problem with the heart, where the pediatrician or the family physician is going to focus on, the typical things we think of: growth, development, immunizations, the other teaching that goes with all of those things. So they should be receiving their childhood immunizations and health guidance, again, from that primary care provider. And again, anytime we want to teach parents, anytime that um, their child who has a heart disorder maybe has a minor illness, especially upper respiratory infections, important that they bring the infant or child in for prompt treatment, again, even with minor illnesses, because especially with upper respiratory infections, they can easily become compromised and their respiratory status is a greater degree than children without any sort of underlying disease. So they can quickly become a lot sicker because of that heart defect. Again, it depends on the extent that it's affecting them. So important that they have both a cardiologist and a primary care physician. And then making sure they understand who to contact when and who's the appropriate contact. Right? Hydration needs to be monitored closely, and that's really so we can prevent dehydration from occurring. Important to know what their baseline tachypnea is, and that with tachypnea, you do have an increase in the insensible water loss. So, any changes in their fluid intake because of illness or changes in their metabolic demand, it can cause excessive fluid loss and getting into dehydration. So, again, monitoring how teaching parents how to watch hydration status and monitoring that closely is very important. It would also be important to review the steps for follow up care and emergencies. So, before parents even leave the hospital with their newborn who has a congenital heart disorder, we want to make sure they have a name and a number of the healthcare professional to call if they would have any questions about their child's health, and make sure they have an appointment set up for that first well child visit with their primary care provider and any specialist, and help them feel reassured that they're not alone in their child's care. There's always somebody to ask those questions to or turn to if something comes up. Again, if parents are unsure whether their child is ill or in distress, it's always better to err on the side of caution and have them either telephone or bring the child into the primary care setting to be checked out. Another important thing that would for parents before they leave the hospital with their newborn who has a heart defect or disorder is making sure that they have been taught CPR. So that'd be really important. Anybody who's really going to be caring for that infant, around that infant a lot, but especially the parents, they need to know CPR before they even leave in case, unfortunately, something would happen with their child. The last thing too is, again, I kind of already hit on that, but making sure all household members have an understanding of the newborn or the child's needs. So not only just knowing CPR, includes their feeding regimen, any medications they're on, how to notice or pick up on signs of distress, and what to do if those would occur. Talking about the cardiovascular system. Cardiovascular dysfunction. It's the most common form of the most common form of cardiovascular dysfunction is congenital heart disease. And we'll talk just a moment what that really means. So cardiovascular dysfunction, it leads to growth and developmental arrest. It's absolutely going to have an effect on the child's growth and development. Um, and we'll see that as we kind of go through the assessment of heart disorders in a little bit. But congenital heart disease, and there's congenital heart disease and there's acquired heart disorders. Congenital heart disease just means there's an anatomic abnormality that the child is what? Child's born with, right? So for your blank, that the child is born with. Where acquired heart disorders is a disease that occurs after birth in both normal and abnormal hearts. We're going to start talking about assessment of heart disorders in children. And one of the first things we do is we start looking at their health history, which incorporates a lot of different pieces. But looking at their health history is important because heart disease can be recognized as early as early as fetal life. We can do fetal echographs that reveal heart anomalies as early as 18 weeks. So for those of you who've had children, um, male or female, I know males can't have children, but meaning like if you're married or significant other or somebody that you are close to has gone, what do they typically go for around that 18, 20-week mark? As long as everything's been fine in their pregnancy, once they've confirmed pregnancy, you typically don't do another one. Ultrasound is really what I'm getting at until that 18, 20-week mark. And that's where they really look at not only just the heart structures, they look at the different structures of the fetus in general, but one of the things they're going to look at is the heart itself. So we can recognize heart anomalies very early on. If heart disease goes undetected in utero, or let's think about there's a lot of women out there who maybe aren't getting prenatal care for various reasons, right? So for whatever reason, whether they are not getting prenatal care, it can go undetected in utero. And sometimes what happens is there's murmurs that are associated with abnormal circulation that sometimes don't get detected until several weeks after birth. And that's just because it takes a while for that pulmonary pressure to continue to drop and then be able to hear that murmur. We use universal screening with pulse oximetry, O2 sat testing in the newborn nursery. And that's becoming a standard of care. And the goal of that is really to increase that early identification of a previously undiagnosed cyanotic heart disease or defect. So again, looking at some general health history things and then getting more in depth about the health history. It would be important to ask about the birth history or having documentation of what the birth history looks like. So with maternal and newborn issues noted in that birth history. We want to look at pregnancy history. Were there any infections? Was mom taking medications or was there drug use present? Because all of those things can certainly lead to poor fetal formation and have an effect not only overall on the fetus, but especially on the heart. We also want to ask about family history. That includes family members who've had cardiac disease before the age of 55, any episodes of sudden death, any other children born with a heart problem. Are there any dysrhythmias? Important to know because some of these disorders have this polygenetic inheritance pattern. So I kind of talk about that in the beginning, how it's important to look at those things because we know that there's an inheritance pattern with some of these defects. It can also certainly occur as an anomaly in a chromosomal disorder. So there's a few different ones listed there. The most common people are familiar with Down syndrome or trisomy 21. They tend to, not all, but tend to be very common with the cardiac disorder or congenital heart defect that forms ASD, which is atrial septal defect, or VSD, ventricle septal defect. And we'll talk about those in a little bit. But certain syndromes, there's oftentimes a cardiac anomaly that can be present with those. It'd be important to also look at the current health status, looking at their medical and their surgical status, prior hospital admissions, what current medications are they on. We want to know about developmental level and their timeline for attaining milestones. Why that's so important? Remember, just said a little bit ago that looking at cardiovascular dysfunction, when a child has cardiovascular dysfunction, they often have growth and developmental arrest or delays. So it'd be important to, again, know those milestones. If they're not growing like they should and they're not getting enough nutrition, because we have a cardiovascular disorder present, it's affecting how well they're gaining weight and getting enough nutrition to support their growth. If they're not growing properly, guess what it's going to affect? Those milestones. So, again, they may not meet milestones on time because they're easily fatigued or they have extended hospital stays. That absolutely can play a part. Being in the hospital for long term, they're not acting like a normal infant in the sense of, they're home and someone's interacting with them and holding and probably trying to work with them, depending on the age of the infant, as they get older for some of those milestones and getting that interaction that we would normally develop with milestones. So if they're in an extended hospital stay, it absolutely can affect their development. It also would be important to ask specific questions that indicate cardiac function. And a lot of those questions really focus on their activity level, if there's been weight gain, if there's been any events of chest pain or syncope. So going back to activity level, an infant's activity level can be evaluated, and it's evaluated by how well they feed. We look at those as indicators of their inability to meet the metabolic demands while they're feeding. And if they're tiring out too easily where they can't finish a feed, they're falling asleep, or they're working really hard during that feeding, again, they're not meeting those metabolic demands. And what can happen is it can lead or be related to poor cardiac function. So, questions to ask a parent: how long does it take them to nurse or to finish a bottle? Do they take frequent rest while they're feeding, right? Are they tiring out and they can't finish stuff? You have to kind of like arouse them to get them to eat a little bit more. Do they become tachypneic, diaphoretic, or show other signs of distress while they're feeding? For older kids, we can assess their ability for activity really based on their ability to keep up with their peers during times of activity, recess, gym classes, participating in sports. Remember, they, for the most part, will kind of curb their activity if they're getting tired. Not all kids, probably not the older ones if they're really competitive, but it'd be important to certainly see how well are they able to keep up with their peers. Again, not only are we asking about activity level, we're asking about has there been weight gain, and usually with thinking about like congestive heart failure, weight gain's a big one, right? If we're holding on to fluids because things aren't working properly. We'd want to know about any events of chest pain or syncope. Those are important to ask about and note. It would also be important to note the child's height, weight, and BMI. So plotting those on those growth charts and seeing what deviations, if any, from their standard or from the standard curve. They may not grow on a normal curve, but they'll maintain their own normal curve. So even though we look at these standardized growth charts, it's still important to look at the child as an individual when we're looking at their growth chart and their growth curve. They may not hit the typical milestones of growth, but they're maintaining their own, and that's what we want to see. We'd also want to assess and look at vital signs. So specifically, really all of them: heart rate, respiratory rate, blood pressure, and O2 sats. So really important to know what normal ranges are for all ages so we can see, are they deviating from the norm? When we're also doing assessment, we want to look at their general appearance. So just do a brief visual assessment. Does the child appear calm and comfortable, or are they really restless? Um, are they lethargic? Are they in any sort of distress? We don't have to touch the child to be able to see these things. So just doing a quick visual assessment. What color are their extremities? Are they pink? Are they more bluish, purple? I'd hope they're not that color, but if we're not perfusing well, we can see changes in what their extremities look like. on that same note, it'd be important to inspect their distal extremities for color and to measure capillary refill time. These can be indicators of poor tissue perfusion. So they tend to have slower cap refill time. Their extremities might be cool and cyanotic, especially in newborns. That's termed a or acrocyanosis. That's normal. That is a normal finding for the first 24 to 48 hours of life. And that should not be confused with cyanosis that's related to heart disease, right? It'd be important, again, measuring those O2 stats to give a more accurate measurement of circulating oxygen levels. Remember, we just said that, especially for undetected disorders in utero, we use O2 sat monitoring in the nursery, in the newborn nursery, to be able to pick anything, essentially pick any disorder up, potential disorder up. So again, monitoring or measuring O2 sat can give us a better measurement. It'd be important to inspect mucous membranes in the mouth. It's the most accurate site to assess because it's not affected by the environmental temperature. So again, looking at the mucous membranes to see, are they pink or are they more cyanotic? Talking about physical exam, there's some things that we're going to look for or look at on the physical exam. It would be important to assess or evaluate for apical impulse, for any thrills, lifts, or heaves, just by simply placing a hand on the left side of the chest. A thrill, you're gonna feel a vibration that's felt secondary to the significant cardiac murmur. A lift, where that means there's forceful cardiac contraction that causes the hand to move up. And a heave would be very forceful cardiac contraction that actually causes the hand to move up and lateral. It'd be important to assess the apical point of maximum impulse, or PMI. That is located at the fourth or fifth intercostal space, at the mid-clavicular line in infants and children. And deviations in the PMI can be an indicator of enlarged heart due to illness, heart fatigue, or heart failure, or congenital heart defects. And of course, lastly, one of the last things we want to do is actually listen, right? So we want to make sure we auscultate. So use both the diaphragm and the bell of the stethoscope. And we're listening for what? Really listening for heart sounds. And what do I mean by heart sounds? We're listening for S1 and S2, or that lub-dub, right? So we call that S1, S2. And we're listening at APTM. What does that stand for? Those are really all your vowels: apical, tricuspid, pulmonic, and mitral. Right? So what are we listening for? We're assessing for heart murmurs. So we want to assess the quality, the pitch, intensity, location, radiation, presence of a thrill, response of murmur to exercise or a change in position. And we can classify heart murmurs as innocent or pathologic. Innocent, it's not usually associated, or it's not associated with any intracardiac disease. And then pathologic is associated with a cardiac anomaly or altered cardiac function. And when you think about listening for S1 and S2, where do we listen? We listen at apical, right? Apical heart rate, heart sound. We're listening to heart sounds. And how long do we listen for? We should be listening for 1 full minute. Again, to make sure we're catching if there's any murmurs present or any abnormal heart sounds. And what we want to hear is nice, clear S1, S2, that is regular. But in kids who have a cardiovascular disease, that's not always the case. Okay, next, we're going to talk about diagnostic tests. So there's lots of different diagnostic tests that are listed here. And if you really kind of just scroll through them on your notes, they're really going from more the least invasive to more invasive or more in-depth type of diagnostic testing. So just a simple one we can do, a cap refill. That's testing their tissue perfusion. We can certainly do a chest x-ray. That's going to help us assess their heart size and orientation, looking at pulmonary blood flow and any associated lung disorders. It can also help us with, if they're looking for fluid collections or effusions. Again, another type of diagnostic test, doing just some lab work. Some basic lab work, such as chemistry and hematology tests, those can really give us a lot of insight. It helps provide insight to their electrolyte balance, their hematologic state, and their acid base balance. It can help us assess alterations that can affect their myocardial function. One that might be really important or we often see is polycythemia. That's typically noted in children who have a cyanotic defect because this develops over time. So, polycythemia is just the body's attempt to produce more red blood cells in an effort to provide more oxygen carrying capacity to the body. So, when we talk about cyanotic defects, kind of keep this in mind because with cyanotic defects, they're not perfusing like they should. Um, so the body isn't getting basically enough O2 to its tissues. So the body tries to go, wait, I need to compensate. Let me produce some more red blood cells so I can carry more oxygen. Well, by producing more red blood cells, really what ends up happening is we have polycythemia. So the body tries to help itself, but it only does so much. It just creates a lot more red blood cells. And if we have a lot more red blood cells, then think about how much thicker that blood's going to be because of the amount, right? So it increases the viscosity as well. Another one lab that we really want to look at is a C-reactive protein or CRP. Why would we want to look at C-reactive protein? That's an indicator of inflammation. So again, with different cardiac defects that are going on, if we've got inflammation within the heart, that can help us tell that there's inflammation in the body. We also want to look at arterial blood gases. Those really help provide a lot of information regarding arterial acid-base balance, carbon dioxide, oxygen, and bicarb levels. So those are all important things to look at. There's a lot of different diagnostics. I'm not going to go through all of them, but ECGs can certainly be helpful. They can provide us information about heart rate, rhythm, their state of the myocardium, presence or absence of hypertrophy, if there's ischemia or necrosis, abnormalities of conduction, the effect various drugs and electrolyte balances have on the heart. We can do halt or event monitors, monitor for 24 hours to give us a more accurate and complete account of everything that's going on with the child's heartbeat. We can do a transthoracic echo, CT, MRI, giving us very detailed images of the heart and chest structures. We can do exercise testing to evaluate the child's condition, especially if we're increasing demands on the myocardial. So doing exercise. So think about like an exercise tolerance test. That's really what that's getting at. We can do cardiac cath, and we're going to go into that more in just a little bit. But that allows doing a cardiac cath helps us give very direct measurements of pressure, as well as help us to visualize the heart and the blood vessels with the aid of contrast. So cardiac cath can be a corrective procedure, or it could be something that's more of a diagnostic. So it goes both ways. It would also be really important to do a good system assessment on the rest of the systems in the body, because a cardiac disorder or dysfunction that is present is going to have effects on every system in different ways. So some of the things we want to look at, what their respiratory status looks like. Do they have increased rate or work of breathing? That could be secondary to an increase in pulmonary blood flow. So basically, if there's more blood going out to the lungs to get reoxygenated, it's putting more workload on that part, which oftentimes you're going to see respiratory distress. When we talk about those increased pulmonary blood flow disorders, that you will see that in their signs and symptoms. It'd be important to assess if they have had frequent upper respiratory tract infections. Again, if there's increased pulmonary blood flow and they're having to work harder, we tend to see these kids have more upper respiratory tract infections or signs and symptoms of upper respiratory tract infections. You'd want to palpate the abdomen for the liver size, looking for hepatomegalia. That would be an indicator that there's poor right-sided heart function. We would want to look at urine output and their feeding tolerance. These are indicators of cardiac output. So infants typically should have approximately 6 to 8 wet diapers per day, but it'd be important to assess how wet are those diapers that they're having. Right? Are they just a little bit wet? Are they soaking wet? Or are they just average? So infants should have about 6 to 8 wet diapers per day. Older children, they should void several times daily. And we would want to assess, what does that urine look like? So for an infant, yes, you can still look in a diaper and tell, is it really dark yellow? Is it lighter? And for older children, you might just have to have them ask, or parent would maybe need to help keep an eye on it for them. So just urine really should be light in color. We know that if it is darker yellow, that tends to mean they're not as hydrated as well. So important to ask those questions. We'd want to look for edema. Edema is a late sign of heart disease in children. Periorbital edema is generally what's going to occur first, but edema is a late sign of heart disease in children. Neurologic status. If they're lethargic or they're not interactive, it may be because they're fatigued or they're experiencing poor tissue perfusion because they're not getting enough O2 out to the rest of the body, right? Making them tired. And we'd want to assess those distal extremities. Remember, we talked about that before. Evaluating capillary refill time. We'd also want to assess pulses. So assessing, how strong they are. Are they weak? Are they strong? Are they bounding? Right? So presence of palpable pulses. Temperature of extremities and their color of their extremities. Those are all indicators of adequate cardiac output. Talk about cardiac catheterization. Cardiac catheterization is considered the gold standard. A cardiac cath gives us very precise measurements of oxygen saturation and pressures in each chamber and vessel. It also can identify anatomic alterations. So I had mentioned earlier that a cardiac cath can be diagnostic, or it's also considered interventional. So diagnostic just means diagnosis of specific heart disorders in anticipation of surgery or some sort of correction. It gives us that good visual, can again give us O2 sat measurements, pressure measurements, all of those good pieces of information. Where interventional cardiac cath is really used to correct an abnormality. So maybe patching a particular defect. You'll see that when we go through some of those congenital heart disorders, that is the typical way that we may repair the defect. Right? So there's some things you have to think about when we're doing a cardiac catheterization. If you're the nurse caring for a child who's going to come in and you're maybe a nurse working in the cath lab, there's some pre-catheterization responsibilities, and then of course there's post-catheterization. So thinking about pre-catheterization responsibilities. When you think about the things you need to do for cardiac cath, whether it be pre or post, this isn't really any different than what you would do for the adult. You guys have learned this information, so draw on the knowledge you have for cardiac catheterization. I know you've talked about it before. I'm going to point out some slight differences, maybe some things that you wouldn't always do with an adult, but you need to do with a child. So we're talking about pre-catheterization responsibilities. If at all possible, take the family, the child on a tour, especially for the child. That can relieve a lot of anxiety about where they're going, what's going to happen, and just helping them understand it doesn't have to be such a scary process. And again, making sure you take into account their developmental level. So preparing that child based on their developmental level for that procedure. Again, let's say they show up for the day, you're the nurse taking care of them in the cardiac cath area, and you're doing all their check-in and getting them ready to go off for the cardiac cath. What are some things you think you might need to do or assess for this child to prep them? Well, we need to get a baseline set of vitals, a full set. That includes O2 sats, and doing an overall good head to toe assessment. So getting that physical assessment, right? Because we need that as kind of our baseline for post-catheterization. We would want to assess for any signs and symptoms of infection, especially thinking about for an infant or a child who's in diapers. it would be really important to assess their diaper area. We would want to assess for severe diaper rash because typically you got to think about what access area do we typically go in, and that's most often is femoral. We do have other places we can go, like brachial, but most commonly we go through femoral access just like the adult. But it would be important to assess for diaper rash because if it's severe enough or there's any infections present, that can certainly lead to the cancellation and needing to be rescheduled. And the reason we don't want to do that, you don't want to introduce any organisms and then have a risk of something like infectious endocarditis, right, occur. So we don't want to introduce any sort of bacteria by doing that cardiac cath. It would also be important to check for allergies, especially allergies to shellfish and iodine. Right? So always assessing allergies. We would want to make sure that they're NPO. So again, that phone call prepping before the pre-catheterization, making sure family knows if their child can or can't eat and for how long before the procedure. Also important to think about what medications that they're on, if they can take those or not. So typically NPO status is 4 to 6 hours prior to the procedure, and then checking if they're on digoxin, if that digoxin should be held or not. We would want to place an IV or a saline lock. That's going to help us give the contrast and use it for any medications like sedation that we may need. It would also be important to locate and mark the dorsalis, pedis, and the posterior tibial pulses on both extremities. We need those for post-catheterization, right, to make sure and assess that there aren't any complications occurring. Now let's talk about your post-catheterization responsibilities. So again, not much different than anything that you would do with the adult. So again, draw on that previous knowledge. One of the big things, let's say you're the nurse taking care of them in the post-cath lab area in the recovery. They bring the child out to you. What's one of your priority assessments that you're going to need to do? You need to assess that pressure dressing, right? Over the insertion site to make sure it's snug, that it's intact, and that there's no bleeding present, right? Want to make sure that it's nice and dry and intact. So we want to assess that frequently. It's usually assessed as just as frequently as the vital signs. So in the beginning, that could be, every 5 minutes times 3, then every 15 minutes times 4, then every hour times a couple hours, whatever may be the protocol of that institution. But we are assessing that pressure dressing every time we assess their vitals. And really what we're looking for, again, making sure it's nice and intact and that there's no bleeding. Let's say everything's going just fine, everything's checking out. So you've assessed them a few times, no issues. It's been a little while. It's time for your next set of vitals and assessment of that dressing. You pull back the sheet or covers and the dressing is saturated. What would you do? Well, you would want to, if there's any bleeding present, you want to apply firm, continuous pressure, and then either, depending on what you have, if there's Vocera or cell phone, or get someone else to notify the physician. Right? So make sure you're applying firm, continuous pressure and notify the physician. When you think about how you're going to position this child in the post-cath area, they need to maintain a supine position and a leg that is straight, especially if that femoral site was used, usually for 2 to 4 hours post-procedure. Again, that helps to keep that pressure dressing secure and prevent a hematoma from forming. We'd also want to assess vital signs, including temperature and distal perfusion frequently. So with our vital signs, our heart rate, our cardiac rhythm, respiratory rate, O2 sat, their blood pressure, everything, temperature. And then also assessing the affected extremity for color and temperature. The child needs to remain flat in bed for 4 to 6 hours or whatever the physician has ordered. That can be a little more challenging with a pediatric client versus the adult. No, we don't give them extra sedation unless, of course, they're just really agitated. We try and use other non-pharmacologic measures to really keep them laying flat and not moving around. So parents can certainly be helpful in soothing them. We can give them some, if they're uncomfortable, some medications, but we try not to have to give them anything more to sedate them or any other narcotics. Again, important when thinking about assessment, you want to assess those distal pulses for extremity and symmetry. Initially, they are probably going to be weak, and that's normal finding, but they should return to their pre-cath state because it can be difficult to find them post catheterization. That's why it's so important in the pre-cath step to mark those spots where they were assessed. So just marking them with one of those um, skin markers where you can place the X where to find it. If the pulse cannot be palpated, then we would want to use a Doppler to try and find that pulse. And if pulse is still not found in the foot, the popliteal pulse should be obtained. Again, if there's any concern and you're not able to find it, especially even after using a Doppler, you would want to notify the physician immediately for any loss or change in the pulse. Again, initially it should be weak, but that should come back pretty quickly to the pre-cath state. It would also be important to monitor I's and O's. Make sure they have adequate urine output. We want to assess for any signs of hypovolemia or dehydration. We want to encourage voiding to promote the excretion of that contrast that we used as well. And then just think about all normal post-op considerations, just like anything else. We want to assess that airway. We still want to do our head-to-toe assessment. And then there's some things we need to teach the, more so probably the parent than the child, but I guess it depends on the age of the child. If you've got a teenager, you can teach them as well. Especially if they're going to be going home. Not all instances do they stay in the hospital. They may just come in for the cardiac cath, be observed, and stay for so many hours and then go home. So it'd be important to do some education. You'd want to teach the parents about observing the insertion site daily for 3 days for redness. You'd also want them to monitor the temperature for 3 days. And again, when you think about those things, why are we having them assess or monitor for temperature and their insertion site? Well, really, we're just looking for the potential of signs and symptoms of infection. We want to make sure they don't do any sort of tub baths until that site has completely healed. They can do a sponge bath or take a shower if it's an older child who's able to do that. We don't want them, sitting in a tub of water. No heavy lifting or strenuous activity or exercise. So typically, again, they don't want you lifting, I think, more than like 10 pounds. So again, not having kids carry in like a jug of milk. Or, again, it depends on the age of the child. Again, no strenuous activity or exercise. So if they're involved in sports, that needs to be curbed for a little bit. There's usually, again, a time period. There's very specific instructions that will be given to the family. Thinking again about post-op catheterization, other things you're looking for or monitoring for are any sort of complications. The most common that we can see following a cardiac cath is dysrhythmias, bradycardia, hemorrhage, hypertension, hypoxemia, or a reaction to the dye. We're going to start talking about congenital heart disorders. So first you have to kind of understand what normal heart development should look like, what that looks like in prenatal life and the fetus, and what is supposed to happen with our circulation after birth. So you have to have a basic understanding before we can get into the various congenital disorders. So first, starting out, normal development of the heart. The fetal heart develops or begins to develop in the first month of gestation. And at about 21 days, the heart begins beating and circulating blood. So between the second and seventh weeks, it changes to a 4-chambered heart. And then if you've already talked about it in OB, you might already be familiar with this part. The lungs in fetal life, are they functioning or non-functioning? They're actually non-functioning in fetal life. So lungs are non-functioning during fetal life. So where is the fetus getting O2 from? And you can't just simply say mama. That's true to a certain extent. We just need to go a little bit deeper in our understanding of where exactly that O2 is coming from. O2 to the fetus is being provided from the placenta. So lungs are non-functioning during fetal life, and O2 is from the placenta. So on this slide, you have what circulatory looks like before birth. That would be picture A, and then what circulation looks like after birth. After we cut the cord, baby takes its first breath, what happens with the circulatory changes. So I highly recommend clicking on the hyperlinks that I have. If you just click on the one that says circulation before birth, and then afterwards click on the one that says circulation after birth, they are both videos from Khan Academy. They do a great job explaining and drawing out the different fetal structures that are present and what happens and what our blood flow looks like. So really important to have that grasp before you go into really trying to understand the different congenital defects. I'm going to talk through basically kind of the overview of what those videos will kind of talk about and fill in your blanks. So talking about circulation before birth. So before birth, the vascular resistance created by those non-functioning lungs causes a greater right side pressure in the heart, greater right side pressure. Fetal tissues will function with low O2 sats, and even the newborn does, at least in the beginning, until that pressure builds up and we start getting circulation through the lungs, right? And getting our O2 there. So fetal tissue functions with low O2 sats. Some different structures that you have present in fetal life. The first one, for the foramen ovale, it is an opening between the two atria. Two atria. So that is normal in fetal life. We want that to be present. That is normal, should be there. So it's basically kind of a little flap. That's an opening that creates circulatory flow between the two atria. Your fetal lungs, they're again non-functioning in fetal life. They actually begin to oxygenate the blood at delivery because they receive blood for development via the foramen ovale during fetal life. That foramen ovale is what helps to change the circulatory pattern or what it would look like compared to after birth. And then another structure that we have that's present in fetal life is something called the ductus arteriosus. The ductus arteriosus. That is considered your fetal circulation bypass. That's what allows blood to come from the right side of the heart and return to general circulation without going where? Remember we said it's our bypass, right? Our fetal circulation bypass. So it's not allowing blood to go to the lungs in fetal life. Those structures are supposed to be there. That's what's supposed to happen, right? Because again, our lungs are non-functioning in fetal life. So it allows blood from right side of the heart to return to general circulation without going to the lungs. That's important. That's supposed to be there, supposed to be used in fetal life. Now, basically all that changes once baby's born, we clamp the cord and they take their first breath. So now we're going to talk about circulation after birth. When the baby first takes their first breath, there's an abrupt change. The umbilical cord has been clamped or cut. Now the newborn needs to really adapt very quickly to receiving oxygen from the lungs, right? So let's talk about those structures we just talked about that are present before birth and what happens to them after birth, or what's supposed to happen. So the foramen ovale, again, remember in fetal life, that's the opening between the two atria. So look for that little structure opening between the two atria. When we clamp that cord, that's going to help stimulate the closure of the foramen ovale. Now, it can take hours to days for that to fully close. It basically becomes kind of like a little, it's like a little flap of tissue because the pressure changes. It creates that flap of tissue to close, and that opening is no longer there, and it just gets absorbed, almost kind of like a ligament that just gets absorbed. So closing or clamping the cord closes the foramen ovale. Your systemic vascular resistance then rises. When it rises, it results in the backup of blood flow. This ends up resulting in increased pressure now on the left side of the heart, which then closes the foramen ovale. So it closes that little flap of tissue and says, nope, blood's not going to go back there because the left side of the heart has such greater pressure. It's pushing that little flap of tissue back. So again, if you watch those Khan Academy videos, this will make a lot more sense, especially if you are a very visual person. They do a great job of drawing this out and showing what happens. So I highly recommend using those videos. I usually show them in class. So they aren't terribly long, like 12, 15 minutes max for each one. The lungs. Let's talk about what happens with the lungs. The lungs begin to function with the first breath, right? So remember, we've clamped that cord. The baby takes their first breath. Breathing helps to stimulate the closure of the ductus arteriosus for your blank. The ductus arteriosus. The lungs expand, which increases the pulmonary vasodilation, which in turn decreases that pulmonary pressure because the systemic pressure is rising. As the lungs become filled with air and pulmonary resistance falls, the blood no longer flows through the ductus arteriosus. Okay, so the ductus arteriosus is a little bypass. If you look at picture A on this slide, you'll see at the top of the, not the top of the aortic arch, but at the aortic arch where your lungs, there's a connection between the aortic arch and the pulmonary artery. So, in fetal life, blood is flowing through that ductus arteriosus because it's not going out to the lungs. So it's going bypassing the lungs and going up to the aortic arch through that ductus arteriosus to go out to systemic circulation. Now, after birth, what happens? Breathing starts occurring, our pressures change in the heart, our circulation has now changed. The foraminal valley is closing, getting smaller. The lungs are now functioning. We should not have blood flowing from basically the pulmonary artery up into the aortic arch because that's going to close off as that, again, takes hours, sometimes days for it to fully close. But shortly after birth, that's going to start getting narrow and narrow. And eventually it will just close off like it's supposed to close off like a ligament. And that structure is no longer open. Right? So, again, that breathing takes place, helps stimulate the closure of the ductus arteriosus, right? So talking about the ductus arteriosus responds to that higher O2 sat, resulting in more efficient pulmonary circulation. Again, it can take hours, even up to days for that to fully close, permanent closure. So they can say it takes up to 10 to 21 days, but it will start closing within hours after birth, right? So as that it basically gets absorbed. It becomes a ligament. It's just absorbed by the body. And after, if all of it closes like it should, then we have normal circulation like we're supposed to, which changes your hemodynamics, right? So now we have altered hemodynamics when we're talking about congenital heart defects if they are present, right? So whenever we have a congenital heart defect present, it changes the way blood flows. It changes those hemodynamics within the heart. So blood is always going to flow from an area of high pressure to an area of low pressure. Blood is going to take path of least resistance. It's not going to work any harder than it has to. So it's going to go from an area of high pressure to an area of low pressure. The result of the cardiac anomaly may be deoxygenated blood is entering into the aorta and eventually the systemic circulation. So blood returning to the heart from venous circulation is usually about 75% O2 saturation. As it passes through the pulmonary capillaries, it loses CO2, binds with O2 from the alveolar air, and it reaches the 98% O2 stats. So that's what's supposed to normally happen. Again, I highly recommend go look at those Khan Academy videos. If you just click on the right where it says the title, Circulation Before Birth, it'll take you, it's a hyperlink, it'll take you right into Khan Academy or launch a Khan Academy video for you. And they'll talk about what that fetal circulation looks like. Same thing. If you click on the title, Circulation After Birth, it'll link you to another Khan Academy video to watch about what happens when we clamp that cord and baby takes the first breath and what happens with all those fetal structures that are open. It's a great visual. Highly recommend watching it. All right, now we're going to actually start talking about our different congenital heart defects. So when we talk about congenital heart defects, they are two major categories, and then there are subcategories how we classify them. So classification of defects, they're either acyanotic defects or cyanotic. So this chart gives you just kind of a quick little breakdown before I go into the different types of defects or classification. So again, acyanotic, and then within acyanotic, you can have either increased pulmonary blood flow defects, or you can have an obstruction to blood flow from ventricles. then you can see the different defects listed underneath there. And then you have cyanotic defects. So with cyanotic defects, your subclassification would be decreased pulmonary blood flow, and then, or I should say, mixed blood flow. So not everything on this graphic are we going to talk about, but the large majority of them we are. But let me kind of explain a little bit better about acyanotic versus cyanotic. So again, our two major categories that we divide them into, again, acyanotic or cyanotic. Acyanotic heart defects have what we consider left to right shifting of blood. So meaning there's oxygenated blood from the left side of the heart mixing with blood in the right side of the heart, and it goes back out to the lungs to be oxygenated again, right? So acyanotic, where cyanotic defects mean there is a right to left shunting of blood, right to left shunting of blood. So it's delivering deoxygenated blood to the body, right? Because that's come from the right side of the heart, which is deoxygenated, going to the left side. And when it comes from going to the left side, it's trying to go out to systemic circulation. So again, you have to really understand what normal circulation would look like, and then where that defect is, how to understand our different classifications. Again, either acyanotic or cyanotic. When we talk about acyanotic or cyanotic defects, again, we're talking about which way is the blood shunting. So acyanotic, left to right shunting of blood, where cyanotic is right to left shunting of blood. The other thing to remember is when we refer to acyanotic and cyanotic, what we're talking about is what does that blood mixture look like inside of the heart? Not necessarily what do they look like on the outside of the heart, but what does that blood mixture? Is it more red? Is it more blue? Or is it purple? Think back to elementary school, right? Red and blue, art class, our red and blue make purple, right? Those tend to be our mixed blood flow. So again, we're talking about what does that concentration of blood look like in the heart, and again, which way is it shunting? So acyanotic, left to right shunting of blood, you're going to be more oxygenated blood, so it's going to have a little more red appearance to it. Where cyanotic defects, you have right to left shunting of blood. It's going to be more blue. You've got more deoxygenated blood that's going out to the rest of the body. Okay, so the other thing I highly recommend is to help you with understanding defects, especially if you're a visual person. I have still pictures. You also have a separate Word document that was with your notes that is just a compare and contrast normal heart versus whatever our defect is. If you're going to print that out or whatever you're going to view it, if you're going to view it on a computer, you need to be viewing it in covered color to really understand, again, if you are more blue in the heart, or you're more red in the heart, or you're more purple. Especially if you're a visual learner, that's going to help you. The other site that if I would have been teaching this in class, I would have been using the website www.pted.org, and it can give you an animation of the congenital heart defect. So highly recommend it. It's got all the different disorders that we talk about. Like I said, normally when I go through this in class, I actually deviate away from my PowerPoint and teach from that website for the visual purposes. So definitely recommend it. It can be helpful in understanding there's some other great resources out there. Khan Academy, another great one. A lot of the different children's hospitals have different explanations that are a little more patient, family friendly explanations, not real in-depth medical side, but gives you the down and dirty of it and shows you good visualization. I do have the acyanotic defects as a whole from Khan Academy linked, not in the PowerPoint, but there is a link to those videos under your PEDS resources. So if you go to Pages in Ivy Learn and then look under PEDS lecture resources, there's specific for cardiac under your pediatric disorders links, or however I have it phrased. It'll tell you acyanotic or cardiac acyanotic, and then there's another link that says cyanotic. They are from Khan Academy. It goes through, again, not all, but the majority of the various defects we're going to talk about. So if you like that, drawing it out and the visual explanation that Khan Academy uses, that's another great resource to use. All right, so we're going to first start talking about defects that increase pulmonary blood flow. So there's 4 defects that we're going to talk about. Most of those being what we consider acyanotic. There is one that is considered a cyanotic defect, but it falls under the increase of pulmonary blood flow. So there are 4 defects we're going to talk about and go through in the next few slides. The first one being patent ductus arteriosus, or often referred to as a PDA. We're also going to talk about atrial septal defect, or often referred to as ASD, and then ventricular septal defect, or VSD. Those are all acyanotic classifications to your increased pulmonary blood flow. The last one we're going to talk about in this category is transposition of the great arteries, which is considered a cyanotic defect, but when I get to it, I'll explain more as to how it falls in the increase of pulmonary blood flow. So those are the 4 first ones we're going to talk about that are increase pulmonary blood flow. Okay, the first structure we're going to talk about is patent ductus arteriosus, or often referred to as a PDA. It is an acyanotic defect, so remember that means left to right shunting of blood, and it falls under the defects that increase pulmonary blood flow, right? So patent ductus arteriosus is when that failure of that fetal shunt fails to close within a few hours or by a few days, right? So usually you should have permanent closure within a matter of several days after birth, right? So the fetal vessel is between the pulmonary artery and the aorta. And you got to think about, now that baby's born, where's your pressure difference? Which way is it flowing? So in fetal life, so before they're born, fetal life, that blood flow is going from pulmonary artery up into the aortic arch because it's bypassing the lungs. Now, we've clamped the cord. So baby's born, we've clamped the cord, they take their breath. Have all those pressure changes that we've already talked about. Now blood flow circulating through the heart like it should, but what happens when it comes up through that aortic arch, because the patent ductus arteriosus is still open, some of it's going to go out through the aortic arch on out to the systemic circulation to the body, like it should. But you're also going to lose some of that oxygenated blood going right back through that patent ductus arteriosus, or PDA. And where does it go from there if that PDA remains open? It's going to the pulmonary artery, which means it's going out to get circulated, right? So not only do you have normal blood flow coming from right ventricle to the pulmonary artery to go get oxygenated, you now have blood flow that's also coming from that aortic arch down through the patent ductus arteriosus. So this is why it's considered an increase of pulmonary blood flow. So again, it's allowing blood from the aorta through the PDA into that main pulmonary artery, which shunts the blood that returns to the left atrium, and it repeats the cycle. So ultimately, you have increased pulmonary circulation, which, when you look at the signs and symptoms that they have, it's going to make sense why they have increased pulmonary circulation, or not, that doesn't make sense about the increased pulmonary circulation. Their signs and symptoms are going to match being pulmonary type symptoms because we have increased pulmonary circulation or increased pulmonary blood flow. So blood from the aorta is fully oxygenated when it's going back down through that ductus arteriosus and then going out to the pulmonary artery. So you're losing oxygenated blood. This is very common in preterm infants, about 20 to 60%. Assessment-wise, they're going to have a systolic murmur early in life. Again, remember that ductus arteriosus, either it starts to close or doesn't close at all, or it just has a little bit of an opening. Just how large that opening is dependent. Each child is different. So we look at it on a case-by-case basis. But they're going to have a systolic murmur early in life. That can change to becoming a continuous murmur as the child actually ages. If the defect is large enough, again, remember we have increased pulmonary blood flow. So if we have increased pulmonary blood flow, your signs and symptoms are going to match respiratory issues or symptoms. You're going to have rales, congestion. They're going to have increased work of breathing. These are the babies that are going to have difficulty feeding. They're too tired. It's wearing them out because it's too much work to try and basically nurse or take a bottle and certainly breathe with that increased pulmonary blood flow. So we have difficulty feeding. If they're having difficulty feeding, they're not getting enough over time. We're not growing like we should. guess what we're going to see on those growth charts? We're more than likely going to see a decline in growth, or we're not growing like we should, even to the point where we could get into failure to thrive. That's your FTT. We can confirm this disorder, this congenital defect, with doing an echocardiogram. And when it comes to management, we always want to try least invasive first and then moving on to more invasive procedures. So our management that we're going to try first is we're going to give them IV indomethacin. That's if there's no spontaneous closure of that ductus arteriosus, or give them IV indomethacin. It is a non-steroidal anti-inflammatory, and it happens to be a prostaglandin inhibitor. So if you remember from the Khan Academy video, guess what? When we clamp that cord, it also does something to our prostaglandin level. It makes it typically drop, which is going to stimulate the closure of our patent ductus arteriosus. However, for whatever reason, that patent ductus arteriosus didn't close. So we're going to give them the IV indomethacin. Again, it's a prostaglandin inhibitor, so it blocks that to help stimulate closure of the PDA. Typically given over the course of 3 separate IV doses, so it's not just a one-time thing. But hopefully that will stimulate the closure. If it doesn't, if that medical management fails or the child is older, then we look at doing other methods that are a little more invasive. So typically what they'll do is an interventional cardiac cath with placement of some sort of device to close off and occlude that access from the aortic arch to the pulmonary artery. So it occludes that flow, so then you don't have blood flowing in the wrong direction or losing that oxygenated blood out to the pulmonary artery. Again, I highly recommend going and looking at that website. That will be helpful. I believe that one has a good visualization of what's happening. I don't think it has a flash player, but a good visualization of what's happening and how we also treat that with a cardiac cath, an interventional cardiac cath. Our next defect we're going to talk about is atrial septal defect, or often referred to as ASD. It is part of the acyanotic defect, so again, meaning left to right shunting of blood. There's an abnormal opening between the 2 atria. So think about your top 2 chambers, your 2 atria. That allows blood to flow from the left atrium to the right atrium, and then continues into the right ventricle and then on out to the lungs. So again, left to right shunting of blood. May not have a murmur associated with it. It could possibly go unnoticed if there's no real clinical symptoms that exist. It really just depends on how large that defect is. This is not the same as saying an open foramen ovale. Okay, so remember in fetal life, the foramen ovale is an opening between the 2 atria. This is not the same thing. An ASD just literally means there's an opening between that wall of the atria. So the foramen ovale, even though it looks like it's pretty much in the same spot, it is not the same thing as saying an open foramen ovale. Okay. Assessment-wise, regardless of the presence of a murmur or not, they may have a fixed split S2 heart sound. If it's a smaller defect, it could possibly go unnoticed. It's probably not troubling them. They're not showing signs and symptoms of a defect or any clinical symptoms of a defect. So it could absolutely go undiagnosed and undetected. If it's a larger defect, they're more likely they're going to show symptoms, right? And again, remember this is acyanotic, left to right shunting of blood, and it falls under that subcategory of increased pulmonary blood flow. So, again, if we have increased pulmonary blood flow, we have pulmonary overcirculation. So your signs and symptoms will kind of match that. We have rales, congestion, tiring with activity again, poor weight gain, possibly even getting into failure to thrive. So again, going back and thinking about those questions we ask in the health history and talking to parents about what symptoms have they noticed. This is the baby who's not gaining weight on that growth chart, who's tuckering out during feedings, isn't able to finish them, maybe having, again, the congestion or what seems like upper respiratory infections or symptoms of an upper respiratory illness, right? It's because there's pulmonary overcirculation, increased pulmonary blood flow. Over time, what's going to happen if we don't fix this is it will lead to enlarged right side of the heart because of that increased volume from that left to right shunting of blood. So enlarged right side of the heart If there is a systolic murmur present, it's not related to the flow through the actual defect of between the two atrium. It's just because the velocity is low. So it's the systolic murmur is really related to the increase in the blood volume traveling across the pulmonary valve, right? Because we have increased pulmonary blood flow. We can confirm this defect with an echocardiogram. Management wise, really just depends on the age of the child, the size of the defect, if they're showing symptoms or not. So if it's a smaller defect and they're not having any clinical symptoms, they'll probably just watch it. They're not going to do anything. They'll just watch it. So no closure, no surgical closure, and just watch it and see if it may possibly spontaneously close on its own. Where if it's a larger defect and they're having symptoms, they're going to manage those symptoms. They're going to try with a diuretic first. So management of symptoms with a diuretic attempted first. Why would they do a diuretic? Think about, again, what's happening with the amount of blood flow. Increased pulmonary blood flow. So increased pulmonary circulation. We're going to use a diuretic, see if that ends up helping and creating a spontaneous closure. If not, then most commonly the way ASD is treated or to get permanent closure is to do a cardiac cath and put in a septal occluder device. So again, if you go to that website I was talking about, they have a great flash player showing how blood is flowing from left to right. And then when you go under the treatment portion of that one, it'll also show you cardiac cath and putting in a septal occluder device, basically patching that hole. And once we patch that hole, we've fixed our problem. We've fixed our blood flow. We don't have that increased pulmonary circulation anymore. Here we're going to talk about ventricular septal defect, or VSD. Again, part of the acyanotic defect, so it means left to right shunting of blood, and it's still part of the subcategory of increased pulmonary blood flow. So this time with ventricular septal defect, we have an abnormal opening between the two ventricles, so those lower chambers of the heart, between the two ventricles. So blood's going to come from left ventricle to right ventricle, and from the right ventricle, it goes out to the pulmonary artery. So most common cardiac defect that's found in children, it's either its own defect in isolation just by itself, or it can be combined with other defects that you'll see we talk about later. It allows that oxygenated blood from the left side of the heart, or the left atrium, to go to the right side of the heart, or the right atrium, which then ultimately increases your pulmonary blood flow, which then leads to increased volume of blood returning to the left side of the heart. So it can actually lead to left side enlargement over time. Assessment-wise, it will produce a loud, harsh murmur, similar symptoms to the PDA and ASD that we've already talked about. So rales, congestion, that tiring with activity, poor weight gain, or failure to thrive. Again, because we have increased pulmonary circulation that's causing those symptoms. Small defects can have a murmur, but they may be actually asymptomatic. And then large defects will typically manifest as congestive heart failure. So think about your congestive heart failure signs and symptoms. Tachypnea, we're going to have poor feeding, again, failure to thrive. Again, because if we've got the left side of the heart is enlarging because we've got too much blood returning from that left side of the heart, you're going to get that left side enlargement. And again, over time we have, or not over time, but we have increased pulmonary blood flow, which is what's leading to that increased volume of blood returning to the left side. So again, you can get this child can get into signs and symptoms of congestive heart failure if we don't fix it or don't do something or recognize it. It can be confirmed by an echocardiogram as well. And management, a lot of times, again, if it's a small defect, a lot of times, and it's not affecting the child that much, then we can just monitor it and see if it will have a spontaneous closure as that child grows. If the symptoms of, or if they're having symptoms of pulmonary overload, and getting into that congestive heart failure type symptoms, then we've got to treat those symptoms. So typically, again, we're going to use a diuretic. Typically, our diuretic of choice, even in kids, is furosemide. So we can do that to help with those symptoms of pulmonary congestion. And again, because they're not gaining weight, they're tiring out, they're not finishing those feeds, these are the kids who are going to possibly need increased caloric density of formula or breast milk. If again, we're having that poor weight gain. So if mom's choosing to wanting breast milk, she's probably going to need to pump breast milk and then feed it via a bottle or an NG tube. And again, adding extra calories to it to make it caloric dense. So most, or not most, but breast milk is standard, is like 20 kilocalories per ounce. Again, we would just make that a higher caloric density to support their growth that they need. So just adding basically extra calories to that breast milk by doing powder and just making it more caloric dense. So it depends on the child. We might make it 24 kilocalories per ounce. It could be 26, 28. It just depends on what that child needs in order to maintain their growth and development. If closure does not occur over time in that symptomatic child, then the child's going to have the more persistent failure to thrive. We can get into deep depressed myocardial function or dilation of the left side of the heart. So then they're going to be referred for closure. So again, we can do this closure, depends on how large that defect is. If we can do it, we're going to do it via cardiac cath. If that is unable to be done, and maybe because it's too large of a defect or something else going on, then we look at doing open heart surgery. So again, we're always going to try least invasive first if possible. But again, it's a case-by-case basis. So cardiac cath or surgical closure would be how we'd manage it if it doesn't do it spontaneous closure on its own. All right, the last one we're going to talk about in this category of increased pulmonary blood flow is transposition of the great arteries. It's actually considered a cyanotic defect, different from the other ones. So cyanotic defects typically have right to left shunting of blood, right? So transposition of the great arteries, it's the second most common congenital defect. And there's a switched position of the pulmonary artery in the aorta. So if you look at the picture on the slide, that will help you. They are actually switched. So your aorta is normally red and your pulmonary artery is normally blue. If you look in the second part of that picture, it's actually reversed. The aorta is now actually blue and the pulmonary artery is actually red. And you also have to look at where those arteries, what ventricle they're coming out of. So the aorta in the transposition of the great arteries, the aorta is now coming out of the right ventricle. Again, so we have deoxygenated blood because it's returned from circulation. So that's, again, why it's blue. And then we have the pulmonary artery rising out of the left ventricle. So that's your oxygenated blood. And think about circulation. If the pulmonary artery is now coming out of the left ventricle and we've got oxygenated blood already, guess where it's trying to go? To the pulmonary artery to get oxygenated again. And that deoxygenated blood that's going through the aorta from the right ventricle, it's not getting reoxygenated. So you keep circulating deoxygenated blood. And really, you end up having two separate circulations. So that's problematic if we don't have another defect present. So it results in two separate circulations. So to kind of explain that a little bit more, the oxygen blood returns from the lungs to the left atrium, goes to the left ventricle, and then it proceeds back through the pulmonary artery and onto the lungs. Where the deoxygenated blood returns from the body to the right atrium, goes to the right ventricle, and back to the aorta, which then supplies deoxygenated blood to the systemic circulation. So again, we have two separate circulating systems. You never get mixing of oxygenated and deoxygenated blood. So it actually ends up being incompatible with life because oxygenated blood never reaches the aorta. If that defect goes undetected or is monitored for a longer time, there's typically an area that allows for mixing of oxygenated and deoxygenated blood, which possibly for the child means there's an experience of increased pulmonary blood flow. So that's why it falls under that increased pulmonary blood flow category. because there's, again, some sort of mixing of oxygenated and deoxygenated blood, which really means we need something else to stay open in order for them to be able to survive. And guess what we want that to be? We want that to be the patent ductus arteriosus. So in normal, think about what's supposed to happen. We've clamped that cord, they take their breath. That PDA starts to close. Only in this situation with transposition of the great arteries, we don't want that to happen, right? And what's going to happen if we don't know anything about this defect ahead of time, we're going to see severe cyanosis shortly after birth because that PDA is trying to close. That PDA completely closes, we have two separate circulating systems. So again, you're going to see severe cyanosis, tachypneic, and they're going to have a murmur possibly as well. So we really want that PDA to remain open. By having the PDA remain open, you get mixing of oxygenated and deoxygenated blood, allowing them to be able to survive until we can get to surgical correction. So in order to make sure we maintain that PDA open, we need to give them a drug to keep it open. So this time we're actually going to give them prostaglandin. We're going to give them a prostaglandin infusion. That's going to be started immediately after birth. That's going to help maintain that patent ductus arteriosus and encourage that mixing of blood. Side effect of it, though, you do have to watch in the infant is apnea and hypotension. So they do need to be carefully monitored. And that's really a life-saving drug. It's until we can get to surgical correction. And we want to do surgical correction as soon as possible, typically within the first 14 days, in order to basically correct these arteries. And what they'll do is they'll just basically cut them and re-anastomose them and put them back in their proper locations so that you get proper blood flow. So it's a pretty big surgery. We're not going to go into the in-depths of it. Just understand they need prostaglandin to keep that ductus arteriosus open, and then surgical correction. Your nursing care before surgery, we want to make sure that they're ensuring O2 sats remain normal for the defect. So because of that defect, they're never going to have high oxygen levels. So it's okay for them to sit at 75, 85%. Now that seems really odd, very different from any other problem we have. You always want your O2 sats to be very high. These guys aren't going to get in the 90s, right? We're happy to keep them at 75 to 85% while we're waiting to get to surgery. Now, after surgery, that's a different story. They should be a lot higher than that. We need to make sure we're monitoring for signs of increased pulmonary blood flow. Because again, remember that when we have another defect, especially if it goes undetected or we're trying to monitor it, we have to monitor for that, again, the mixing of oxygenated, deoxygenated blood, because they're going to possibly experience increased pulmonary blood flow. So we would want to watch for increased pulmonary blood flow. And then, of course, make sure that we're supporting the family and explaining what's going to happen with surgical correction and what therapeutic management looks like with giving that prostaglandin. So big takeaways from this. Again, if the PDA closes, we have two separate circulating systems. It's incompatible with life. We need the PDA to stay open. In order for that to stay open, we need to give them a prostaglandin infusion until they can get to surgical correction. The next couple disorders we're going to talk about fall under the cyanotic category of defects, and then their subcategory defects that decrease pulmonary blood flow. So now we're talking about decreased pulmonary blood flow. So again, these are considered cyanotic defects, which typically means we have right to left shunting of blood. We have, and these two types we're going to talk about are decreased pulmonary blood flow. So we're not getting enough blood flow out to pulmonary circulation. So there's two we're going to talk about, and that's tricuspid atresia and pterology of Fallot or Fallot. People pronounce it differently. Right, the first defect we're going to talk about that falls in that cyanotic category, so right to left shunting of blood, and the subcategory of defects that decrease pulmonary blood flow is tricuspid atresia. So tricuspid atresia is when the tricuspid valve is completely closed. And that means if it's completely closed, it doesn't allow blood to flow from the right atrium to the right ventricle, which means it can't reach the lungs for recirculation, right? So no blood flow from right atrium to right ventricle, which means it can't reach the lungs. So again, there's your decrease in pulmonary blood flow. In most infants, the blood actually crosses through the patent foramen ovale into the left atrium, which then ends up bypassing the lungs in that step for oxygenation. Why is it going from, um, or why is it going through the patent foramen ovale into the left atrium? You have to think about pressures. If it's come in, so blood has come in to that right atrium, it has nowhere to go since that tricuspid atresia is present. So that valve is closed. It can't get to the right ventricle. So think about how much pressure there is on the right atrium, which is going to, again, remember, blood's going to flow from path of least resistance, from high pressure to low pressure. So the pressure is so high, it's from keeping that foramen ovale open, preventing it from closing. So blood's going to flow from right atrium to left atrium. Again, the unfortunate part is it's bypassing the lungs and that important step for oxygenation. It actually reaches the lungs for oxygenation because it's being shunted back through a PDA, a patent ductus arteriosus. Right? So we have a couple different problems. Not only is our tricuspid valve completely closed, our foramen ovale is open, and we also have patent ductus arteriosus. Again, you got to think about how much higher the pressures are and how that has changed because that tricuspid valve is completely closed. Assessment wise, they're going to have severe cyanosis and tachycardia and dyspnea shortly after birth because guess what's going to try and happen? The ductus arteriosus is trying to close like it's supposed to. And if it closes, we've got problems. It never reaches the lungs. So again, as that PDA closes, we're going to see severe cyanosis, tachycardia, and dyspnea because we have decreased pulmonary blood flow, never getting reoxygenated. They can also end up developing signs and symptoms of congestive heart failure and certainly failure to thrive. So guess what? Do we want that PDA to close? We sure don't. We want to keep it open, right? So what are we going to give them? We're going to give them prostaglandin again. We're going to give them an infusion of IV prostaglandin to keep that ductus arteriosus open until we can get to surgery. So once we get them on to go to surgery, they can repair that defect. There's a procedure, and I'm not that worried about you knowing the name of the procedure. I want you to understand physically what's happening with our blood flow because of that tricuspid atresia, what other structures are open and how does that change our blood flow, and then the fact that they need prostaglandin in order to get to surgery so surgery can be life-saving. And the procedure they do is called a Fontaine procedure, and basically they'll construct or do a reconstruction of the vena cava to the pulmonary artery and allow a shunt. So again, big takeaway is they need the prostaglandin until they can get to surgery. Right, the next defect we're talking about is taurology of Fallot or Fallot, also referred to as TOF. It is a cyanotic defect, which means right to left shunting of blood. And this one also is part of the subcategory of decreased pulmonary blood flow. So there's actually 4 anomalies present with taurology of Fallot, and that's pulmonic stenosis, ventricular septal defect, an overriding aorta, and last but not least, there's right ventricular hypertrophy. So I'm going to explain all those in just a second. So with your pulmonic stenosis, that just means that pulmonary artery is stenosed, which means if it's stenosed, we can't get blood out of that right atrium to go out to pulmonary to get recirculated. So it's backing up into that, or I shouldn't say the right atrium, the right ventricle, my apologies, to the right, it can't get out of the right ventricle. Again, if it can't get out of the right ventricle, then ultimately it might back up into the right atrium as well. And you got to think about if we're not getting blood out through that pulmonary artery because of that stenosis and that's backing up, what's that do to that right ventricle and the workload on that right ventricle? Well, that's what creates that right ventricular hypertrophy. It's actually secondary to the pulmonary stenosis. And the degree of cyanosis is directly proportional to the degree of the pulmonary stenosis. The other 2 defects, like I said, so we've talked about the pulmonary stenosis. or the pulmonic stenosis, and we've talked about the right ventricular hypertrophy. So I said they also have a VSD, or ventricular septal defect. Well, that ventricular septal defect, again, we have right to left shunting of blood. Pressures on the right side of the heart are much greater compared to the left. So blood's going to flow from right to left. So right to left shunting of blood through that VSD. And the last thing that they have is what's called an overriding aorta, which means that aorta normally is sitting really nice into the left ventricle. Well, because of everything that's occurring, now the aorta is sitting right on top of that VSD. And because it's sitting right on top of that VSD, when you've got blood flowing from the right ventricle to the left ventricle, that's, remember, right side of the heart, deoxygenated blood, and it can't get out to pulmonary. So pressure is greater going across that defect that got deoxygenated blood that's trying to go out, or not trying, it will go out to the aorta. As well as you've got normal blood flow coming into the right atrium, right ventricle that's oxygenated. So you're getting oxygenated blood flow as well going to the aorta, but you're also picking up, because of that VSD and the pulmonic stenosis, that deoxygenated blood that's coming across right to left shunting, and the aorta is sitting, or that defect is or the aorta is sitting right over that defect. So it's picking up deoxygenated blood as well. That's also going out to systemic circulation. So again, you have decreased pulmonary blood flow. Assessment-wise, they can have a systolic murmur, and that systolic murmur is really due to the turbulent flow out of the right ventricle. So that outlet flow tract has a lot of turbulence, which creates the systolic murmur. And again, they have greater than normal right to left shunting of blood across the VSD. So the child's becoming more, or will be more, deoxygenated. They can have what's called a hypercyanotic or TET spell. The exact etiology of that is unclear. I think maybe there's a number of mechanisms that's proposed, including increased infundibular contractility, peripheral vasodilation, and hyperventilation, which causes this hypercyanotic spell. So whenever a child has, and with Trelegy flows, the only time that they're at this increased risk for what we call the hypercyanotic or TET spell. When a child has a hypercyanotic TET spell, can occur anytime. Anything could spark it, from just crying because maybe they're hungry or they're upset. Maybe they're trying to have a bowel movement. Maybe we're taking them in for blood work, or they're in the hospital and we're doing blood work and we have to stick them for that blood work. Anything can really spark one of these hypercyanic spells. We never know when it will occur. But when it does occur, the child is going to become distressed and irritable. They're going to have periods of lower saturation. That's temporary. They're probably partially irritable because they're not getting enough oxygenation, right? So they already don't have great oxygenation. When one of these occurs, it makes it even worse. So management, again, this depends on, are they at home when this occurs, or are they in the hospital? So management for the family, if they're at home when this occurs, we want the family to try and soothe that child if they're upset, and place them in what's called a knee-chest position. So bring the child's knees tightly up to the chest. What that actually does is increases the systemic vascular resistance, therefore by putting an increased pressure on the left side of the heart, or the systemic side, and that can help force blood back through that pulmonic valve, thereby increasing oxygenation, or oxygen to the blood. And it would be important for, as soon as one of these occur, once it's over, for the family to notify their cardiologist, because that now indicates the child has become more compromised and that they need corrective surgery sooner rather than later. If the hypercyanotic or TET spell would occur while the child is in the hospital under our care, for nursing, again, immediately, whatever sparked it, let's say we were doing a blood draw, you'd stop that blood draw, that's no longer important. Immediately place that child in that knee-chest position, and then we're going to do what's something called blow-by oxygen, which blow-by oxygen is basically, if you've ever seen like a simple face mask and like the tubing to like a trach or a BiPAP, where you've got that thicker tubing that's also hooked up to humidification for the oxygen. You just put the simple mask on the end of that tubing, and the oxygenation being on the wall with the humidification. And then instead of trying to strap this on, because one, think about it, the child's probably already irritable. They're probably kind of being a little fussy and agitated, not wanting to sit real still during this because they're not getting a whole lot of oxygen. They can't breathe well, right? And you're trying to hold them in an chest position, you can't really strap this on. So, that could actually end up creating more stress for the child by trying to strap this on their face. So, really, all you do is you turn your O2 on full blast as high as you can get it, and you just take that mask and you just hold it in front of their face. You don't want to strap it on, just hold it in front of their face. You've only got one hand free because you're already putting them in that knee chest position, right? And then just allow that oxygen to blow into their face. So that's considered blow by oxygen. It actually enhances the circulating oxygen, and it helps possibly dilate the distal pulmonary bed. In some cases, some physicians, they may actually order some sort of sedative or some other sort of medication, like an alpha adrenergic antagonist, or agonist, not antagonist, agonist. There's different ideas. Sedatives may actually help enhance the right to left shunting, or I shouldn't say not help enhance. What the idea is, the sedatives are controversial because it can dilate the systemic circulation, which would enhance the right to left shunting, which would really mean you'd have worsening cyanosis. And we don't want that. We're trying to resolve that cyanosis at the moment, or that worsening cyanosis. Again, in some cases, they may do an alpha adrenergic agonist. The idea is that will vasoconstrict and may actually facilitate more flow out of the pulmonary artery. Whatever the physician may order, if they have it ordered PRN for a hypercyanotic spell, you can go ahead and give that through the IV. And the idea is hopefully somehow whatever the drug is, it's going to help them get over this and help oxygenate them a little bit better. So the big takeaway, I don't care where it's happening, hospital or home, put them in an chest position, calm that child in the hospital, give them 100% O2 blow-by, and then we need to notify the physician once the spell is over, because again, they're going to need surgery sooner rather than later. That means they've become compromised. Management-wise, they do need surgery in order to correct tetralogy of Fallot. So it's usually done at around approximately 3 to 6 months of age. Which again is why we're so worried while we're waiting for surgery that they could have one of these hypercyanotic spells. So typically what they'll do is they'll do closure of the VSD, or that ventricular septal defect, and they'll repair that stenosed pulmonary valve. And then of course any associated right ventricular outflow tract anomalies they can repair. Again, make sure you're teaching parents to minimize those hypercyanotic episodes during that waiting time for surgery, teaching them to place the child in the knee chest position to reduce symptoms. Our next category of defects we're going to talk about are defects with obstruction to systemic blood flow. Obstruction to systemic blood flow. So there's 3 of them. They all happen to be considered acyanotic defects. So the 3 of them we're going to talk about is coarctation of the aorta, or COA. The next one is aortic stenosis, or AS. And the last one is pulmonary stenosis, or PS. Our first defect that we're going to talk about that is a defect with obstruction to systemic blood flow is coarctation of the aorta, or often referred to as COA. It is an acyanotic defect. It's not the traditional left to right shunting of blood that you think of, but you got to think about, what does that heart mixture look like? Is it more red or is it more blue? So with coarction of the aorta, there is a narrowing of the aorta as it nears the ductus arteriosus due to a constricting band. So there's a narrowing of that and part of that aortic arch, or just beyond the aortic arch, right around where the patent ductus arteriosus would be. Assessment-wise, and well, actually, even before thinking about assessment-wise, because it'll make sense when you think about the signs and symptoms. So if you've got a narrowing or constriction there, think about what happens to your oxygenated blood. Where's it supposed to be going? It's supposed to be going out to the rest of the body to oxygenate our extremities and our organs and everything else, right? So If we can't get enough blood through, that means there's not enough blood going out to our entire body because it's not getting through there, right? So your signs and symptoms are going to make a little more sense when you think about that it can't all get through, right? So um, typically, or very frequently, children aren't actually diagnosed with coarctation until they grow and they're noted to actually be hypertensive. But guess what? When do we start screening those blood pressures on a routine basis? Not until they're age 3, right? Unless something comes up that there's a problem, we're not routinely screening that. So again, we may not catch this right away. And usually what ends up happening, that narrowed area frequently distal to the right subclavian artery, so then the pressures before that area actually increase and then refer out to these vessels. So it actually causes an elevated blood pressure in the right arm. Okay, so occasionally they can also have a murmur noted. If coarctation is detected in infancy, they are usually more critical and they will produce heart failure within weeks of birth. So they're going to require immediate surgical intervention. In order to detect the presence of coarctation defects, there's some signs and symptoms that we look for or would want to be aware of. Because again, remember, in some cases, this isn't noticed until the child grows and starts to have more problems. So we might see weakened or absent femoral pulses compared to the upper extremities. So it'd be really important to compare your pulses in all extremities, not only just right to left, but also upper to lower, because again, those femoral pulses are going to be weakened or certainly absent compared to the upper extremities. They may have frequent nosebleeds, headaches, vertigo, or leg pain. So thinking about really more nosebleeds, headaches, and vertigo, your pressures in the upper body are a lot higher compared to the pressures in the lower body. So the reason they would get leg pain is because blood and oxygenation is not getting there like it normally would if we didn't have this coarctation. So they tend to complain more about leg pain with activity because, again, they're using up what little oxygen there is, and it's creating that pain because they're not getting enough. As well as you can have increased blood pressure and O2 sats in the upper extremities compared to the lower extremities. So again, if this is possibly a defect we're thinking about or we're wanting to screen for, it would be important to actually check all 4 extremities for blood pressure and O2 saturation to really be able to compare. And what you're going to see is that upper body, the pressures are a lot higher compared to the lower body. Management-wise, correction can be done either by a cardiac cath and doing a balloon angioplasty, basically opening up that stenosed area, or in some cases they may need to do a surgical repair, and usually what they'll do is they'll just resection that area of narrowed tissue and they'll reanastomose the ends together once they've taken out that anastomose area. In the next slide, I'll show you a couple pictures that a student sent me a couple years ago from physician she worked with. His child went through it, and the child was about age 2. So it's just a couple pictures where they actually surgically cut out that stenosed area. So when you look at those, just think about how that would make so much more sense if you're not getting blood flow through there systemically, how your pressures are higher in the upper body compared to lower body. And again, think about those signs and symptoms. The next defect we're going to talk about with obstruction to systemic blood flow is aortic stenosis, or AS. Again, part of acyanotic defects, there is a narrowing or a stricture of the aortic valve. So assessment-wise, they can have a murmur, they're going to have left ventricular enlargement over time, they might complain about chest pain, they're going to have lowered cardiac output. Management-wise, typically we're going to stabilize them with a beta blocker, calcium channel blocker. That's going to help reduce or prevent that further ventricular hypertrophy. And then we're going to do a balloon angioplasty or dilatation by cardiac cath to help open up that narrowed area. That will help relieve that obstruction. And in some cases, if that doesn't work or we have repeated obstruction, then they may actually replace the valve or do a surgical intervention for that recurrent stenosis or the ineffective balloon angioplasty. The last defect we're going to talk about that's an obstruction to systemic blood flow is pulmonary stenosis, or PS. Again, it's considered an acyanotic defect, and we have narrowing at the opening of the pulmonary valve or artery. This can lead to right ventricular enlargement because it's backing up. So assessment-wise, we can have a murmur, cyanosis. Children may complain about exercise intolerance, so not being able to keep up with their peers, cardiomegalia, and CHF. Again, CHF because, again, getting into heart failure because if blood can't get out to that through that pulmonary artery or valve, it's just going to back up, creating right-sided heart failure. Management is doing typically a balloon angioplasty by cardiac cath to help open up that narrowed or stenosed area, thereby relieving the obstruction. All right, our single ventricle defect. We only have one we're going to talk about, and this is going to wrap up our congenital heart defects. So the one we're going to talk about in the next slide is hypoplastic left heart syndrome. So our last defect, hypoplastic left heart syndrome, or HLHS, is a cyanotic defect, and there's an underdevelopment of the left side of the heart with a small left ventricle and aortic atresia. So really complete underdevelopment of the left side of the heart. So on this slide in the picture, again, comparison to normal heart versus what hypoplastic left heart syndrome looks like. That left side completely underdeveloped. When the left side of the heart is underdeveloped, it leaves that left ventricle essentially non-functional. It lacks the adequate strength to pump blood into systemic circulation. That also leads to right ventricular enlargement because, again, things aren't working right. The right side is going to become enlarged. They can have severe cyanosis, and they have severe decrease in cardiac output. Again, it doesn't have the strength to pump it out to the systemic circulation. Management-wise, they need the drug prostaglandin again to maintain the patent ductus arteriosus, or our PDA, until we can get to surgical correction. And when they do surgical correction, it is done in several stages. There's several different procedures they do. The big thing I want you to take away, left side of the heart, really small, non-functioning, which means we're not pumping adequately. We're not getting good systemic circulation. They need prostaglandin to mean that PDA to really get circulation and mixture of oxygenated and deoxygenated blood. And then, so again, giving prostaglandin until we can get to surgical procedure, and then they're going to do various surgical procedures at different ages. Those are the Norwood procedure is the first one. It's usually done within first week of life, followed by then what's called the Glenn procedure, which is usually done somewhere between 3 and 8 months, followed by the Fontaine procedure, which is typically done between 18 months and 3 years of age. All right, so now we've wrapped up all of our congenital heart defects, and now we're going to move into our acquired cardiovascular disorders. So there's 4 of them we're going to talk about. One you should be super familiar with, and the first one being congestive heart failure. So we're going to talk about not only congestive heart failure, but we're also going to talk about Kawasaki's disease, rheumatic fever, and infectious endocarditis, which you should be kind of familiar with that one as well. All right, our first acquired cardiovascular disorder, we're going to talk about congestive heart failure. You guys should be super familiar with this one. Congestive heart failure does not look really any different in a child compared to the adult. So build on the knowledge you already have. There's just some slight differences in not really the medications or the treatment plan, but thinking about like digoxin, like our heart rate, when we can give that or when we would need to hold that. So not a new concept here. This should be really a lot of review. Our congestive heart failure is congestive heart failure. signs and symptoms are the same, and really management for the most part is very much the same as what you would do in the adult. So simply, congestive heart failure is the inability of the heart to supply an adequate amount of oxygenated blood to meet the metabolic demands of the body. It really just refers to a cluster of symptoms and physical exam findings that are really secondary to the underlying process, whatever's really causing the congestive heart failure. So our etiology, it's the most common cause of congestive heart failure in children, or the most common cause of congestive heart failure in children, are congenital heart defects that produce an excessive workload on the myocardium, cardiomyopathies because there's metabolic disorders, infectious diseases, drugs, Kawasaki's disease, or myocardial dysfunction after heart surgery. So regardless of what our underlying cause is, the outcomes are the same. One or both sides of the heart is unable to pump effectively, which means eventually, if the root problem's not corrected, we're going to have an eventual failure, right? And we want to avoid that. We want to correct whatever our underlying problem is in order to manage the congestive heart failure and hopefully correct it. Our pathophysiology. If congestive heart failure is not corrected, the heart muscle itself becomes damaged. A damaged heart muscle actually leads to what with your cardiac output? You really should be saying decreased cardiac output, right? So damaged heart muscle leads to decreased cardiac output, which then in turn leads to decreased blood flow to what specific organ? What are we most often worried about or have a lot of problems with? And that would be decreased blood flow to the kidneys, right? That decrease of blood flow to the kidneys will lead to the kidneys reabsorbing what two things? What likes to go together? Sodium and water, right? So the kidneys are reabsorbing sodium and water. That reabsorption just leads to hypervolemia, which actually that ends up increasing our workload on the heart and congestion of pulmonary and the systemic circulation. So you should already kind of be familiar with right ventricular failure versus left ventricular failure. I'm not going to go through those. You can review that if you need that right there in your notes. All right, now let's talk about the assessment of congestive heart failure. So again, regardless of the underlying etiology, children will initially present with very similar clinical symptoms. The two biggest ones being tachycardia and tachypnea. Things we might see a little bit different depending on the age of our child, whether it's an infant or a young child or an older child. Again, some of our symptoms might vary, but most will present with tachycardia and tachypnea. That's really no different than the adult, right? So for infant and young children, we often see poor feeding. Guess what? Poor feeding, they're tiring out. Again, we're not growing like we should because we're too tuckered to take in our feedings. So on our growth charts, guess what we're going to see? Probably failure to thrive, right? Talked about that several times before in this chapter. So again, poor feeding, failure to thrive because again, our caloric expenditure, what we're expending, the amount of calories we're using is far greater than the caloric intake. So again, you get into failure to thrive. We have rapid respirations and use of accessory muscles for the infant and young child. They tire easily. They might be diaphoretic or they're having difficulty sucking because of the dyspnea and the energy that it requires to eat. Where for an older child, they might be complaining about fatigue or just being tired in general. They tend to have exercise intolerance. So guess what? They're curbing their activity. They can't keep up with their peers. They're having breathlessness. We might start seeing weight gain, and that's because of that fluid overload, that hypervolemia, right? Regardless of the age, but depending on the degree of heart failure and the amount of time that the child has experienced heart failure, our clinical manifestations may reveal hepatomegalia, a cardiac gallop, or enlarged heart on a chest x-ray with or without pulmonary edema. So very specific clinical manifestations. Again, a lot of these should look just like the adult. Kind of have just a general overview. I don't expect you to memorize all of those, but you should have a general idea. And again, what goes with right-sided versus left-sided heart failure. If you have impaired myocardial function, again, you're going to see your tachycardia, your inappropriate sweating, decreased urinary output, decreased blood pressure, gallop rhythm, failure to thrive. Okay, where pulmonary congestion actually suggests which side failure. You should be, when you're looking at those symptoms, look what they have to do with. Again, all pulmonary, so that's left-sided. So again, tachypnea, dyspnea, retractions, again, increased work of breathing for the infant, activity intolerance, grunting, recurrent respiratory infections. Remember, that's important to ask about in that health history, right? Where systemic venous congestion suggests what side? Should be right-sided heart failure. So you tend to see weight gain, hepatomegalia, the peripheral edema, especially periorbital. Remember, excuse me, the peripheral edema is a late sign in children, but if they start having edema, they're going to present with periorbital edema. Getting into the therapeutic management for congestive heart failure. Management is really twofold, which means we want to symptomatically manage the patient and we want to treat the underlying cause of that heart failure. So if that was a congenital heart defect, fix that congenital heart defect, ultimately, hopefully fixing the congestive heart failure. But in the meantime, you have to manage those symptoms that they're having of congestive heart failure. And we have 4 goals of treatment. Our 4 goals of treatment for congestive heart failure: decrease fluid overload, enhance the myocardial contractility, decrease afterload to ensure adequate perfusion, and we want to decrease the workload on the heart. So not in any particular order, but those are our 4 goals, and we're going to talk about those further in my next slide. You also want to be certain the outcomes that are established are realistic and that they are individualized for the child. There's not, one approach that works for everybody. You have to look at the individual child, how much signs, symptoms they're having, how much it's affecting them, and really not characterize, but really create your therapeutic management and your goals around that individual child. So not all children may be able to attain normal vital signs. It's why it's so important to know what's the baseline for that child and where do we want them sitting kind of as a goal, or in general, where do we start to get concerned if that's falling out of what's a normal range for that child, right? So again, knowing baseline of vital signs for that child is really important. Children should be comfortable and able to participate in regular daily activities, regardless of the actual heart or respiratory rate. So now we're going to start talking about our 4 goals of management. First one we're going to talk about is to improve our cardiac function. So for your blank, improve cardiac function, which really what we want to do is increase contractility and decrease the afterload. Our drug of choice to improve myocardial contractility is what? What do we use with adults? Digoxin, right? So same thing. So digoxin is our drug of choice to improve myocardial contractility. By giving digoxin, what that does is it increases our cardiac output, it decreases our heart size, it decreases our venous return, and thereby relieving edema, right? So that will help improve our cardiac function. It's really important for nursing to think about what their responsibilities are, what those include when we're giving digoxin. Always important, always need to check a dosage with another RN before administering digoxin. And that's just to make sure, again, that calculations and dosing is appropriate for that child. So if dosing is appropriate for the child's weight and their electrolyte status, so that'd be really important before we give digoxin, knowing what lab values would look like. Specifically, when we're thinking about our electrolyte status, our potassium level. Is it normal? As long as it's normal, digoxin is considered therapeutic. So it would also be important to know not only our electrolyte and specifically potassium, but also knowing our digoxin level if we're checking that on a regular basis. Nurses need to be able to recognize signs of dig toxicity. So Again, some of these might look a little bit different than the adult, and you again have to take into um, account the child's age because maybe the child can't report some of these signs and symptoms. So really important to be able to know signs of toxicity. That would be a good thing to know. Some of those signs of ditch toxicity: nausea, vomiting, dizziness, diarrhea, headache, arrhythmias, or bradycardia, right? Bradycardia. If the child is bradycardic for their age, again, that's why it'd be important to know what is expected for their baseline for that child. They may not fit the normal vital signs for a child who does not have a cardiac disorder, right? So again, what's the norm for them in whatever their disorder is or whatever is going on? So if the child's bradycardic for their age, and the heart rate is not their normal baseline value, you need to be consulting the physician, right? Our provider. You would not, this is where it is different than the adult. You do not administer if the heart rate or your beats per minute is less than 100 beats per minute in the infant. If they are less than 100 beats per minute, you hold that digoxin, call the physician, and get an order to hold it, right? Because that means they're getting into ditch toxicity. And for the older child, really we're getting at probably like 2 and older, then we're talking about less than 70 beats per minute for the older child. So if they're not an infant, 2 or older, less than 70 beats per minute. Again, different than the adult. So if I would ask you a question about whether or not you would give a medication, it would be very obvious based on the age, but you definitely need to know those because that would help tell us if they're getting into toxicity, easy for me to say. And before going to administer it, not only do we need to look for these signs and symptoms, we need to be checking their heart rate. Do we rely on a monitor or do we actually auscultate the heart rate? We should be auscultating the heart rate, correct? And we should be doing that for 1 full minute at apical. Right? So listening to that heart rate and counting it. When teaching parents about digoxin administration for home, you might want to go back and review that box about giving digoxin safely at home and teach parents how to administer it, what signs and symptoms or side effects to look for about digoxin, looking for dig toxicity signs and symptoms, and how to count an apical pulse for 1 full minute prior to administration. So that's something that they would learn before they would ever leave the hospital and be checked off on. So dig is our most common drug, the preferred choice that we would give to improve our contractility or our cardiac function. However, in some cases, they can also use ACE inhibitors. For testing purposes, I want you to focus on the digoxin. Our next goal is to remove accumulated fluid and sodium. So for your blank, remove accumulated fluid and sodium. By doing that, we're going to decrease our preload. Our diuretic of choice that we give kids, furosemide, or brand name Lasix. So furosemide is our diuretic of choice. What that does is it actually helps block the reabsorption of sodium and water. And it also happens to be a what type of wasting diuretic? Potassium wasting diuretic, right? So again, important to know our potassium levels, as well as furosemide can actually enhance the effects of digoxin. Again, why it's so important to know signs and symptoms of toxicity. So furosemide blocks that reabsorption of sodium and water. It's a potassium wasting diuretic and it can enhance the effects of digoxin. So important to know and look for toxicity. We also need to know about potassium supplements. So knowing when they might need a potassium supplement. So we would need to know our potassium level. So looking at our electrolyte labs, specifically the potassium. We also need to know and monitor our serum potassium levels, especially before administering Lasix, or I should say furosemide, right, our generic. Again, there's multiple things you need to do when we're giving these different drugs before you actually give it, things you need to be monitoring. How do we know the drug is effective? We're always assessing effectiveness of the drug. We can simply do that by doing a daily weight. That's probably one of the most important. Getting that daily weight at the same time, using the same scale, And for infants, we typically put them in a dry diaper only. Um, no other clothes, just a dry diaper only. And then for older kids, again, you just want to make sure if you're weighing them in a gown, same type of gown, we're using the same scale, same time of day to effectively monitor to see how effective the furosemide is. And doing eyes and nose. Eyes and nose would be really important in monitoring if they're having edema, monitor their level of edema as well. So INO and edema assessment. Our next goal in the therapeutic management of congestive heart failure is to decrease the cardiac demands. Decrease cardiac demands. By decreasing cardiac demands, we're decreasing the workload on the heart. So some things that we can do: bed rest, right? Um, Organize and consolidate that care so they can rest. That's really important for healing and for growth and development. We don't want to constantly be going in and doing something. So really trying to consolidate that care to allow for rest periods. Maintain body temperature. An elevated temperature can actually increase the metabolic needs and demands of the body. We want to monitor and treat infections promptly. Keep their vaccinations up to date. So, right, trying to avoid other infections. We want to reduce efforts of breathing. Increased respiratory rate may actually be an early sign of increasing congestive heart failure. Place them in a semi-Fowler's position, so head of bed, 30 to 45 degrees. Use of supplemental oxygen, but there's usually a standing order, so supplemental oxygen may be needed for that child. We can also medicate the irritable child. That does not mean we sedate them, okay? Use of just different drugs like acetaminophen, or something certainly a lot stronger, a narcotic like morphine, especially during what we talked about, those TET spells, right? That may be something that we use. We don't just do it all the time, but we really want to make them comfortable so they're not using all this unnecessary energy and increasing those metabolic demands and the workload on the heart. Um, Again, a lot of those drugs, if they're irritable, can help decrease their oxygen demands related to the crying and irritability. We also want to decrease their anxiety. So having parents being allowed to be at the bedside can help decrease the patient's anxiety and make them more comfortable. Helping keep parents calm too is really important. Um, Even though a child may be young, if a parent's really anxious, kids can feed off of that. They can sense it. They don't necessarily always know what's wrong, but it's amazing what kids pick up on, even though they don't really necessarily always understand cognitively what's happening. But if parents really anxious, the child can pick up on that. So it's really important to help keep the parent calm so it will allow the child to be calm. Our last goal we're going to talk about for congestive heart failure, for the management of congestive heart failure, I should say, is to improve tissue oxygenation and decrease O2 consumption. So, improve tissue oxygenation and decrease O2 consumption. We're going to do that by monitoring their oxygenation. So, monitoring their O2 sats and again, keeping them greater than what the MD has ordered. Remember, these kids who have congenital heart defects or getting in congestive heart failure are not going to sit up in the middle to upper 90s. It may be okay for them to sit in the upper 80s or sometimes the low 80s. It just depends for that child what the physician writes. So just keeping their O2 sats greater than what the physician has ordered, which may mean they may need supplemental O2. So if they do, again, giving them some supplemental oxygenation. We want to give them small, frequent feedings of high calorie, high fat meals daily. And we want to also give them, in some cases, a supplement. So that could be protein shakes. If it's a breastfed infant, mom may need to pump and then give it via a bottle. That will help conserve energy and allow for also caloric concentration. So if we need to make it more caloric dense to meet their growth, we can do that as well by having mom pump and then increasing those calories. So again, your next bullet point may require daily increased calories to meet the demands and ensure adequate weight gain. Our next acquired heart disease that we're going to talk about is Kawasaki's disease. So this one's probably unfamiliar to you. This is not something that you see in adults whatsoever. It only occurs in children. So Kawasaki's disease is an acute febrile syndrome, febrile syndrome that's associated with generalized vasculitis. So that means it affects all the blood vessels throughout the body, including coronary arteries, which is what we're most concerned about. You'll see as we go through this. Vasculitis is the principal finding and it's life threatening. So vasculitis is principal finding and life threatening. The vasculitis can actually lead to a formation of coronary aneurysms, which can predispose the child to thrombus formation and high risk of myocardial infarction. So that's why we're so worried about not only the vasculitis, but especially those coronary arteries. The etiology itself is unknown. There's some thought that maybe there's some genetic predisposition, or there's a strong suggestion that it could be part of an infectious precursor. But again, we're not exactly sure. More common in winter and spring, and males are affected more than females. And 76% of cases are less than 5 years of age. So occurs in less than 5 years of age. It can occur beyond 5 years of age, but most commonly they're 5 or under. And there's no specific test or labs that we can do to say 100% this is Kawasaki's. Really, a lot of the diagnosis and testing that we do is a diagnosis of exclusion, meaning there's no imaging or laboratory test that can diagnose it directly. We do a lot of other things and rule other symptoms or other diseases out, and then we're kind of left with must be Kawasaki's based on all of this information. So we do have some clinical criteria that is established to help with diagnosing Kawasaki's disease, and that's what we're going to talk about next. So assessment for Kawasaki's. It's actually divided into an acute phase, which is usually week 1, and a subacute phase, which is week 2 and 3. And I'm not super worried about you necessarily like, oh, week 1 you're going to have this, and week 2 or 3 you're going to have this. I just want you to understand overall, this is something that takes quite a bit of time to recover from. But our different criteria for diagnosis, and this isn't getting into, we'll get into the acute and subacute phase in just a little bit, but our criteria that we look at for diagnosis of Kawasaki's, if they've had a prolonged fever, a fever that's greater than 100.4 degrees Fahrenheit of 5 or more days, so a prolonged fever of 5 or more days, and they have 4 or more of the following symptoms. So they may have some of these, they may not. Excuse me. They have changes in their hands and feet. So they have erythema, edema, peeling. I'll show you some pictures in just a few other slides. They can have a polymorphous exanthem, which is a diffuse maculopapular rash on the trunk and extremities of their body. Bilateral conjunctivitis without exudate. They have changes in their lips and mouth. So they have erythema, strawberry tongue, dry cracked lips, and they can also have cervical lymphadenopathy. Next, we look at the changes in laboratory data for Kawasaki's. We can see thrombocytosis, leukocytosis, and we also look at the ESR and the CRP levels, and those are usually elevated with Kawasaki's. So elevated or increased ESR and CRP, and their liver enzymes as well are going to be elevated. So elevated liver enzymes. They can also have mild anemia present. We also continue to look at the changes in their infectious and the inflammatory markers. Those help mandate a thorough investigation into the possible cause. So again, if there's no definitive cause, we've ruled out all these other things, and their symptoms fit into the criteria that are listed above, then that usually means they have Kawasaki's disease. In the beginning, we want to do during the initial diagnosis, or we want to get an echocardiogram that helps provide a baseline of coronary imaging. The coronary arteries in the beginning don't have a lot of changes from the vasculitis. We're worried about over time what happens because of the vasculitis. So coronary artery changes aren't apparent when we first get that echocardiogram. It's really to get that baseline. And then we're going to use that when we do a follow-up at weeks, 2 weeks out, and then again somewhere between 6 and 8 weeks out. We compare those echocardiograms back to our baseline, and we're looking for the development of aneurysms potentially. Getting into more specifically your acute phase versus your subacute. The acute phase is considered that first week. The child is very irritable, for your blank, very irritable, and they're uncomfortable because of the fever and the inflammation that's going on, that vasculitis. They can have joint pain from all the inflammatory process as well. And then in the subacute phase, which is weeks 2 and 3, that starts about approximately day 10. That's when you're going to see the skin discriminate, especially on the palms and soles. That skin discrimination does not hurt. It's not painful at all. They just have some peeling of that skin, especially like around fingertips, again, palms and soles of their feet. We also can see that their platelet count rises. Their platelet count increases, which then leads to the increase for the possibility of clot formation. So if an aneurysm forms in the coronary artery, and that accumulating thrombi can dislodge, which can lead to an obstructed blood flow distally in the coronary artery, thereby leading to myocardial ischemia and infarction. All right, we're going to talk about the therapeutic management for Kawasaki's disease. It's really focused on addressing those immediate symptoms and preventing the long term consequences, like a coronary aneurysm. So it's primarily supportive measures because that child is so irritable and they're not wanting to take adequate oral intake, because you can tell, especially from some of those pictures, those dry, cracked lips, that strawberry tongue. It's all very red. It's swollen. It's irritated. They just don't feel good, so they aren't taking in the best adequate intake. So things that we can do that are supportive in symptom management is antipyretic for the fever, so give some Tylenol or ibuprofen can be helpful, and then IV fluids to make sure they are staying well hydrated. And then one of the main drugs that we do give them is IV immunoglobulin or IVIG. And we give that in a high dose to reduce the duration of the fever and to also help with the incidence, reducing the incidence of coronary artery abnormalities. So we want to give that, there's a specific time frame we can give it. We want to give that within the first 7 to 10 days of that fever. So right when they're having those prolonged fevers, we want to give that, need to do it during that acute phase. And in some cases, we can even do repeated doses if the fever does not break. So IV immunoglobulin, again, help reduce the duration of the fever, and we're going to help reduce the incidence of coronary artery aneurysms. And then the other thing that we're going to give them is aspirin. So for your blank under, or the main blank under therapeutic management, we're going to give them aspirin. And if you're kind of thinking, wait, I thought we didn't give kids aspirin. Normally we wouldn't. However, the benefits of giving aspirin in this situation with this disease far outweigh the risk with giving aspirin. So we don't typically give aspirin anymore, and because we know that kids have what's called Rye syndrome with that. But in this case, again, our benefits far outweigh the risk, and most times it's more of a short-term course of aspirin that they're going to get. So we give the aspirin. Initially, it's for the anti-inflammatory properties. So again, think about all that vasculitis that's occurring. We give them aspirin. That's going to help with that inflammation, help reduce some of that risk with the coronary artery abnormalities. Initially, it is a high dose that we give them. You don't need to memorize how many milligrams per kilogram. I just want you to understand they need the IVIG and they need aspirin. So we give them high dose initially. That'll be continued for a few days after the fever has broken. And then once the fever has actually broken, we're going to reduce the dosage. So they'll get a lower dose, kind of like a maintenance dose of aspirin. And they will continue that. It's no longer as an anti-inflammatory, but it becomes more as an antiplatelet dose. Again, trying to reduce that risk for coronary artery aneurysm. So they'll continue on a low dose once a day for 6 to 8 weeks. If there's no evidence of coronary artery abnormalities, they'll just do that low dose for 6 to 8 weeks. If, let's say, they go back and they do a follow-up of that echocardiogram at 6 to 8 weeks out, and they have some coronary artery abnormalities, they will continue that aspirin low dose indefinitely. So they could stay on aspirin long term. Most cases they don't need to, it's just for that 6 to 8 weeks. But again, if there were changes to the coronary artery, then they would continue on that indefinitely. So the big takeaways for your therapeutic management, again, they need IVIG and they need aspirin, and then it's really kind of comfort and support measures. Your nursing care, again, comfort measures that we can teach the family or help the family with is going to really be rocking, holding, or distraction. Remember, you've got an irritable child who doesn't feel good. They've got all this vasculitis going on. And when I say they're irritable, this is not the typical irritability of a child. This is a little much more extreme, typically very hard to console. And this irritability lasts for a long time, up to 2 months. So that's really hard to deal with as a parent. They're not going to stay in the hospital for 2 months. So we got to teach parents what things we can do to help their child. So again, rocking, holding, distraction. During when the fact that they have all this edematous area and we want to prevent pressures, so we want to protect those edematous areas from pressure, and so we're not getting like pressure ulcers and skin breakdown. So make sure their clothing is not restrictive and it's not irritating the rash that they also have. Because their lips are so dry and cracked, we might want to suggest applying a lip balm that'll help protect those lips as well. And we want to offer extra fluid, so help maintain hydration. So even if they're on IV fluids, still continue to offer oral fluids, and then eventually they're going to get off the IV fluids. We just want to make sure they maintain hydration. That can also help reduce some of that mouth tenderness. Probably want to be careful what type of fluids. If they've really got a lot of irritation in their mouth, you don't want to be given something like orange juice. Not the best idea, right? Things that are going to be more soothing. Need to monitor eyes and nose. They tend to have more of a poor appetite, and generally their eating is poor. Again, it's a systemic illness. They've got mouth sores, abdominal pressure from the swollen lymph nodes. They just don't feel great. So, monitoring that INO, again, maintaining hydration status or watching that can be helpful, or would be important, I should say. Encourage them to continue to brush their teeth despite discomfort, because we want to prevent tooth decay and ulcer formation. So again, we want to make sure we're providing good mouth care. And then recommend for their diet soft, non-irritating foods like gelatin, things that don't require a lot of chewing. You don't want acidic fluids because that could certainly sting or burn. And then teaching. For follow-up monitoring, we want to teach parents that child is going to need an echocardiogram at 2 weeks and out, and then again at 6 to 8 weeks. Again, we're monitoring and comparing that echocardiogram and looking for looking for coronary artery abnormalities. Again, teaching parents that the irritability can persist for up to 2 months, and to be able to prepare to deal with that or help them deal with that. And again, that the peeling of hands and feet is painless, even though it might kind of look uncomfortable. It actually is not painful at all. It's not hurting the child. And then the last thing is parents need to be taught CPR if they don't already know it. And again, that's because of the vasculitis, the risk of coronary artery abnormalities, and the risk for having myocardial infarction. Our next acquired cardiovascular disease that we're going to talk about is rheumatic fever. So, rheumatic fever is an autoimmune disease that occurs as a reaction to a group A beta hemolytic streptococcus. So, it's a reaction to group A beta hemolytic streptococcus. So, this is a complication of a recent strep infection, specifically pharyngitis. So, if you remember back when I talked about respiratory, we talked about a complication of that strep infection could be rheumatic fever. So, here we are, we're going to talk about rheumatic fever. The pathophysiology for rheumatic fever, it is inflammation from a immune response, which leads to the inflammatory lesions that are found on heart, blood vessels, brain, and the joints. So at approximately about 10 days after the recovery from pharyngitis, ends up happening a autoimmune response or leading to an autoimmune response. that begins and it can last for many weeks. What it actually does is it gradually damages the left heart valves. Right? So, etiology and incidence. It's infrequently seen in Europe and North America because we've done a really good job about making sure we have done a lot of education and making sure that we educate about treating or testing very sore throats for strep throat and then adequately treating and educating about finishing antibiotics. Most importantly, though, the causes of cardiovascular morbidity and mortality amongst the socially and economically disadvantaged populations worldwide is really where we see these in those um, places or the cultures where they're not getting tested or the knowledge is not there or the resources is not there to test and treat this. So most often in children 6 to 15 years of age is where this is going to occur. Peak incidence is 8 years of age because guess what? Who's getting the strep infections? Your school age child, right? So makes kind of sense to see a peak incidence there. When we talk about assessment of rheumatic fever, these signs and symptoms are divided into major and minor symptoms according to what's called the modified Jones criteria. Right? And in this pictorial, you can see a nice way to try and memorize that by a mnemonic. But the major criteria are carditis, which about 50% will present with carditis, usually an apical systolic murmur from the mitral insufficiency. So that's your first blank under major criteria. Carditis. Your next one, they can have polyarthritis, where multiple joints are inflamed, and they possibly also can have fluid accumulation. So polyarthritis. You can also have something called chorea, which is the loss of voluntary muscle control, which can lead to dysfunctional speech, facial grimacing, and poor hand control. You can also have subcutaneous nodules, which are on hard bony surfaces of the joints. And they can also have the erythema marginatum rash, which is predominantly on the trunk of the body. The minor criteria for your first blank, a fever. So, a fever. They can also have arthralgia, which is joint pain. They also have, when you look at their lab values, they have elevated SED rates, so an ESR, an elevated ESR, C-reactive protein, leukocytosis, and they often also have a history of, or we would want to evaluate for a history of previous rheumatic fever, and also looking for prolonged PR interval. So again, major and minor criteria. And when we diagnose them, they must have two major manifestations or one major manifestation and two minor manifestations. Of these, the heart involvement is the most serious, obviously. Again, the effects that it has on the heart. Again, looking for diagnosis, there's a lot of important laboratory findings that we're going to look at. One of the first ones we want to look at, or they will have, an elevated ASO titer or I'm going to totally slaughter that one. I'm not even going to try. An elevated ASO titer, which just tells us there was an evidence of a recent streptococcal infection. We also look at those inflammatory markers that I talked about before, ESR and CRP. Those are elevated, right? So the elevated SED rate and the C-reactive protein. And we also want to get an echocardiogram because we want to evaluate the extent of cardiac involvement. Our therapeutic management for rheumatic fever. Well, if this was a result or a complication of a recent strep infection, what do you think we need to treat or treat with? We need antibiotic therapy, right? Because again, go back to what's our cause? It's a group A beta hemolytic streptococcus. So antibiotic therapy is begun as soon as we obtain a throat culture and necessary blood work. Typically what we're going to give them for antibiotic is IM or PO penicillin. Typically PO penicillin, but in case you have somebody who compliance may be an issue, or access to getting the antibiotic prescription filled, then IM may be a choice to do, but typically it's PO penicillin. So we're going to do PO penicillin for a full 10 days. Full 10 days. We all are also going to give them an oral non-steroidal anti-inflammatory to help reduce any inflammation and joint pain that's going on. And in cases of, especially if they're having the chorea, we can give them phenobarbital and diazepam. That will help reduce those purposeless movements of the chorea. When it comes to teaching, again, the big thing is we need compliance with prophylactic treatment after the initial treatment is completed. So they're going to get the initial antibiotic for 10 full days, and then we are going to put them on preventative or prophylactic treatment afterwards as well. So again, that can be given either IM or PO. PO is more common. Again, IM injections are painful. But if you're worried about somebody with compliance, IM may be the better way to go. So typically, preventative therapy continues for at least 21 years of age because of the high susceptibility of reoccurrence. And if the child has incurred valve damage, they could be on preventative therapy until at least 40 years of age. Important to make sure thinking about preventative antibiotics prior to procedures, especially dental procedures, because most common strep viridans are a cause from having dental work and causing other infections. So antibiotics prior to especially dental procedures, but could be other procedures as well. And we always want to advise parents to make sure anytime their child has a sore throat, get it checked out, get it cultured, find out is it viral or bacterial. And if it's bacterial, then making sure that they get proper antibiotic treatment. All right, our last disorder we're going to talk about with the acquired heart disease or cardiovascular disease is infectious endocarditis. You should be kind of familiar with this one. I'm sure you've heard it in the adult, so not much different in kids. So we'll go through this one pretty quickly. But infectious endocarditis is inflammation and infection of the endocardium or the valves of the heart. The incidence and pathology, it's increasing due to increased survival of children with congenital heart disease. That high velocity bloodstream of some defects creates force, uh, and that thought is it damages the or endothelium. Indwelling catheters such as like PICCs can injure the endocardial or endothelial layer, which then allows for a deposit of red blood cells, platelets, fibrogen, which then bacteria like to adhere to that damaged endothelial layer, trapping that bacteria and then evolving the vegetation. So it results in a localized endocardial injury and vasculitis. Um, Infectious endocarditis is generally caused by Streptococcus viridans and Staphylococcus aureus. Right? So, like, thinking about patients who are prone, like we just talked about with rheumatic fever, needing antibiotics before dental procedures because, again, the risk with the strep viridans could certainly put them at greater risk for infectious endocarditis. Assessment wise, the acute presentations, they have a high spiking fever. Again, think about your cause, Streptococcus viridans or the Staphylococcus aureus. So high spiking fever. They have a very toxic looking appearance. They just look sick. They have symptoms of congestive heart failure may be present. Not always, but may be present. So think about those symptoms of congestive heart failure we've talked about or that you already know about. Murmurs are frequently noted too, and that's because of the destruction of the cardiac valve tissue. They can also have some subacute presentations, maybe just a persistent low-grade fever, malaise, weight loss, arthralgia, fatigue, rigors, or diaphoresis. So some of those are a little more general. Those are considered your subacute presentations. When it comes to diagnostic testing, we're going to do a blood culture, and if we have a positive blood culture, obviously we're going to know what that organism is. So getting a blood culture is going to help us verify what organism it is, or organism that we're dealing with, so we can treat it appropriately. We're going to also get an echocardiogram. That's going to allow for that visualization of the vegetation and the damage of the heart itself. So it allows us to see the valve destruction and the perforation, if there's rupture of the chordae, development of any valvular links. It just gives us a very clear picture of what's going on. We can also do some other lab studies besides getting a blood culture. We can look at their proteinuria or hematuria, leukocytosis, and typically they're going to have an elevated erythrocyte sed rate, so an ESR, an elevated ESR. Treatment wise, it's really aimed at the underlying bacterial infection. So an extended course of antibiotics is necessary. So typically they're going to get antibiotic therapy for 4 to 6 weeks via IV, like a PICC line, and then afterwards they'll continue on for prophylactic antibiotics, especially prior to invasive procedures like dental work.